experimental pre-test and post-test design. The course was designed as a non-clinical simulation-intensive training program aiming at providing the theoretical and practical tools to safely approach the operating room as junior anesthesiologists. This was based on 5 different modules, and the modules were preoperative assessment, anesthesia planning, preparation and execution, airway management, intra-op, major cardiac event, and pain management. Teaching strategies employed included lectures, small working groups, skilled trainers, medium and high fidelity stimulation sessions, and on-site hospital visits. And the results were pretty impressive. As you can see over here, this compares the pre-test versus post-test, and all of the scores are, even the median score and the maximum scores are higher as compared to the pre-test. So how to create a competency-based curriculum? We need to establish quality improvement competencies that physicians should exhibit at the completion of the training program. The quality improvement competencies need to be measurable for assessment purposes. Quality insurance competencies should conform to external validated criteria such as national and local accreditation standards for health facilities. The QA competency should reflect best practice, both now and in the future. QA competencies should be amenable to iterative changes, and they should use plain language, avoid jargon to ensure that everyone understands. So what's the way forward? The anesthesia training program must provide all components of training outlined in the goals and objectives of the institute. It must be organized such that residents are given graded professional responsibilities under appropriate supervision according to the level of training, ability, and experience. It should allow residents to perform their activities at a desired level according to their ability without direct supervision. Trainers have to show evidence of CPDs and keep up with CMEs. Goals and objectives of the educational program must be structured to reflect the desired competencies. All residents must receive a copy of goals and objectives when they join the program and annually as the goals and objectives are updated. The program education committee must ensure that a resident participates in a specific scholarly activity each year or maybe twice a year. So what changes should we expect or make? Our training program must be comparable to international training programs by generating quality improvement programs. Training must focus on curriculum and patient care and must produce doctors who are knowledgeable as well as safe for the patient. Burnout is an important factor which must be gauged, and a consensus on minimum working hours must be made and should be applied to every institute uniformly. Trainees must be satisfied with the institute they are trained at, for which the institute must not only prepare the trainees to sit in the exam confidently, but also understand the limitations of working as a trainee. With the increasing inflation, it becomes an important element to make changes to the stipend as it would be expected. By 2025, our training program should be such that the rate of brain drain is reduced to a minimum and trainees feel balanced in their training no matter which institute they are trained at. Thank you.
Any questions or suggestions or any comments?
Thank you, Akbar, for a very nice presentation. I just want to make a comment that the term quality assurance has been replaced by quality improvement internationally.
Yes.
So that's the term that should be used now, because sort of assure nahi karni hoti, usme improvement bhi lani hoti hai. Thank you.
Thank you.
Thank you. I would like to invite Dr. Sajjad Alam from Local National Hospital. And he is going to talk on approach for safe provision of anesthesia and MRI. Currently, he is working as final year resident at Local National Hospital. Dr. Sajjad Alam.
Assalamu alaikum, everybody. It's Dr. Sayyed Sajjad Alam. I'm resident anesthesia, critical care pain management in Liaquat National Hospital. And the topic of my presentation is to approach for safe provision of anesthesia in MRI. So the objective of the presentation is to know about MRI and its anesthesia concerns. The MRI zones, what are the challenges we face in MRI, the problems we face in MRI, and the indication of anesthesia in MRI. As we know that MRI is used increasingly to improve accurate diagnosis and define plans for therapy. The technique for MR imaging makes considerable demand on patients who are required to remain more or less immobile in a confined space for approximately 30 to 60 minutes. The long cylindrical configuration of the MRI tunnel may be frightening to the patients and provide limited access and visualization of the patient by the anesthesiologist to sedate the patient for the scan. The MRI zone, according to the American College of Radiology, has defined 4 safety zones within MRI facilities. These are donated zone 1 through zone 4 and correspond to the level of increasing magnetic field exposure and hence potential safety concerns. The access to these zones is restricted in MRI facility and hospital, and the boundary of each zone in this 4-zone safety system is defined by its purpose and distance from MRI scanner. MRI zone 1 is an area where the people are freely accessible to the general public, where the magnetic field poses no hazard such as the entrance to the MR facility. MRI zone 2, patients are under general supervision of MR personnel. It often includes the reception area, dressing rooms, and MRI screening rooms. MRI zone 3 access restricted by physical barriers such as doors with coded access. Only approved MR personnel and patients that have undergone MRI screening are allowed. The MR control room is in zone 3. MRI zone 4 is the room where the magnet is located. Access to the zone 4 should only be possible by passing through zone 3. Zone 4 is designated so that the wall of the magnet room contain the 0.5 empty line of or 5 gauge line of the fringe field of the magnet. So the challenges we face in MRI, the choice of anesthesia could be sedation or GA. Always prefer to choose any mode of anesthesia in which airway should not be compromised. So pre-op assessment and airway examination are very important before sedation or general anesthesia. Monitoring equipment has to be specifically made to be an MRI compatible, and the equipment may malfunction in proximity to the magnet because of the high magnetic field strength. The ferrous object brought into the scanning room may become dangerous missile, potentially injuring the patients or MRI technicians or damaging the scanner. ECG introduced problem with both image degradation from wire leads acting as an antennas and inability of the ECG monitor to discern the ECG from background static magnetic field and radio frequency pulse. Voltage induced in the wire leads may poses burn and electrical shock hazard to the patients. It is very important to keep the limb leads close together in the same plane parallel to the magnetic field. It is also very important to make sure that all the leads are insulated from the skin of the patient. The pulse oximeter are susceptible to interference from the changing magnetic field and will occasionally be briefly deactivated by radio frequency pulses. It is very important to use a non-ferrous pulse oximeter and to place the probe on the distal extremity as far as possible from the scan side. When an image is, when the ECG is not available, it is useful to follow the pulse rhythm and rate with the pulse oximeter. Blood pressure monitoring during MRI can be accomplished by using oscillometric method, Dynamap. Invasive blood pressure monitoring can also be obtained in MRI. High pressure, low compliance extension tubing connected to the arterial catheter with a transducer placed at the level of right atrium beyond the 50 gauge line can be used without magnetic field altering transducer performance. Capnograph has been successfully used, however, because of the long gas pathway, the waveform shows a prolonged upslope. Although the end tidal CO2 concentration are not accurate, it is useful to monitor respiratory rate, to follow trends, and to detect if a circuit disconnection has occurred. Temperature monitoring can be accomplished in MRI with the temperature probes that use radio frequency filters and with non-ferromagnetic skin temperature strips that use a liquid crystal display. Care must be taken to avoid hypothermia in all the patients, especially in pediatric population. Airflow directed through the scanner can cool an infant rapidly. Warm bags of intravenous fluid, single-use thermal packs, airway humidifications, and covering the patients are the ways to avoid excess heat loss. There are several MRA compatible anesthesia machine available in the market. The machine currently is in use is made by Omeda and use a ventilator that is pneumatically driven by an aluminum oxygen cylinder. The North American Drager anesthesia machine has an MRI electronic ventilator as well. Well, so the problems, the most common problem we face in MRI is patient accessibility. So the patient distance from the anesthetist create a problem with the airway management, intravenous access, patient visualization, and monitor application. If unintentional extubation occur, it is necessary to discontinue the scan and bring the patient out to the floor to the foot of the scanner bed. Reintubation must take place outside the magnetic room because the laryngoscope batteries are ferromagnetic. Risk from the burns can be minimized by following some simple precautions. Check the insulation on all monitoring wires and cables are intact. Do not form loops within the magnetic board. Minimize contact with the cables. Remove any wire or leads not in use. Separate cable from the skin. Keep the cable and sensor away from the examination area. For example, place a pulse oximeter on the toe of the patient whose head is being examined. Auditory consideration, of course, it is very important. The operation of the MRI coils produce a loud thumping noise. It is very important to place earplugs in the ears of the patient undergoing a scan. There has been reported to the temporary or permanent hearing loss following MRI examinations, and the loud noise may also necessitate the deeper level of anesthesia. The contrast agent which is commonly used in MRI is gadolinium, which has a high therapeutic ratio and a low incidence of side effects. The side effects includes headache, nausea, vomiting, burning at the site of injection, and heaves. The ferromagnetic objects, the attractive force of the magnet exerts a substantial pull on ferromagnetic object, and when free can move object towards the magnetic center with a dangerous speed. For example, Caesar, pagers, oxygen cylinders become missile and are all dangerous risks inside the scanner. Individual objects can be tested for ferromagnetism with a powerful handheld magnet outside the scanner prior to bringing them into the magnetic room. Even the non-ferromagnetic implants must be treated with care if they are in close proximity to the region to be scanned. Indication for anesthesia is the need for immobility. Some scan can take 20 minutes while the other can require over an hour. So the movement of the patient at any point during the scan can degrade the quality of a final image by the production of motion artifacts. Infants and children and confused or developmental delayed young adults will not be cooperative during an MRI scan. The patient anxiety is a problem that may prevent a patient from going into the scanner. The confined space, the loud noises, the temperature of the magnet, and the length of the procedure has been found to be the main cause of distress. Sedation has provided a solution to many of these problems. Airway protection, the patient who are unconscious, critically ill patients, and the patient with a head injury may require tracheal intubation, controlled ventilation, and anesthesia in order to perform a scan. The anxiety and claustrophobia, some young adults may have a fear of being a confined space and may not tolerate a scan without sedation or anesthesia. So, the preoperative assessment and evaluation of the airway is very important before any kind of anesthesia or sedation. The standard ASA monitoring, which must be MRI compatible, should be done during the scan. Anesthetist must stand and keep an eye on the patient airway and vitals in MR during the scan. After the completion of MRI, all the patients should be shifted to the post-anesthesia care unit for complete recovery. Thank you.
Any questions or comments, please? So this concludes our session. So I would like to invite the speakers for collecting their certificates. Dr. Maria Hashmi, please come here to collect your certificate.
Dr. Maria Hashmi. Sir, इधर आ जाओ. Thank you, Dr. Maria. Dr. Akbar Mistry. Dr. Sajjad Alam, please come on stage. Thank you, Dr. Sajjad. May I request Dr. Professor Mehdi Hassan Mumtaz sir to come on stage to present the certificate to Dr. Saleh Khashkeli and Dr. Aftab Khatri. Thank you, sir. With this, we'll conclude our session, part A of the session 2. We will move on to the session B of part 2. This session is basically a young consultant session, and we will like to invite Professor Ismat Wasim Chaudhary. Professor Sir is basically head of the Department of Anesthesia at Akhtar Saeed Medical Dental College, Lahore. He has served for over 20 years as a professor and head of anesthesia at Sheikh Zayed Hospital and Federal Postgraduate Institute, Lahore. He has special interest in pediatric anesthesia, and he also runs the pain clinic. Please, round of applause for him. Now I would like to invite Professor Dr. Fawzia Ali. Madam is a professor at Sindh Institute of Urology and Transplantation, SIUT. She also holds a position of anesthesia faculty member at CPSP. She has interest in teaching and training the trainees. Please welcome her on stage.
Assalamu alaikum. We start second session of young consultant, and the time limit for each speaker is 15 minutes and 2 to 3 minutes for question answers. The first speaker of this session is Dr. Mujib. He is a consultant and head of the department, head of anesthesia department at the Kidney Center. He has a special interest in critical care, pain, and regional anesthesia. He is going to talk about myocardial injury and non-cardiac surgery. Very interesting topic.
Assalamu alaikum and good morning Today's topic, my topic is on the non-myocardial injury after non-cardiac surgery. Disease burden. Preoperative mortality of, I can't see, excuse me. Switch the screen. You split it on the other screen. That's what. Okay, thank you. Sorry for the disruption. Okay, so myocardial injury after non-cardiac surgery. Thank you. Probably this will be time not counted in this. Okay, so perioperative mortality after non-cardiac surgery is 1 to 2% among more than 45 years old. Approximately half of the deaths related to this are cardiovascular. In the USA, 27 million people go for non-cardiac surgeries, and about 50,000 people suffer for the post-operative cardiac MI. And there is in the world 234 million surgical and obstetrical procedures performed globally each year. So you can see there is a huge burden for these patients. Traditionally, the MI was defined by the WHO criteria, which tells that there is a ECG criteria and the cardiac enzyme criteria. But in the perioperative MI, the problem was that patients were heavily sedated and anesthetized, and they have less transient changes on the ECGs. CKMBs are relatively non-sensitive and specific to the cardiac, and the coexisting skeletal muscle injury caused the rise of the CKMB. So it was difficult to identify the perioperative MI. This was the criteria for the WHO, which said that the symptoms of the ischemia, new ECG changes in the STT changes, or new onset LBB, or Q waves in the ECGs are considered that patient has got MI. So there was a need of redefining this definition. There was occasionally rise and fall of cardiac biomarkers, preferably troponin in the myocardial ischemia, and there was cardiac symptoms, ECG changes, and imaging. For the imaging, ultrasound was used, echo, in which wall motion abnormalities were the criteria. Studies using serial troponin demonstrate that most of the MIs occurs in the 24 to 48 hours. Cardiac biomarkers were frequently elevated during the non-cardiac surgeries, and that's why they were ignored. The patient did not have symptoms, though they were considered that the patient does not have MI. So there was also another confusion. That was what is the perioperative MI and the patient have a ischemia. So difference between the perioperative MI and ischemia was not well defined. So this was also a confusion for the previous definitions. So based on the prognostic importance of postoperative cardiac markers, a new clinical diagnosis was needed. And that defined that myocardial injury after non-cardiac surgery was name given to this entity. And this included the myocardial infarction and ischemic myocardial injury. Like ACS, previously MI and ischemia was different, but when the chest pain started, ACS was combined. So now the MINS has been combined with the myocardial infarction, ischemia, both have been combined in this. So the new definition says that at least one postoperative cardiac troponin concentration that exceeds 99th percentiles upper reference limit. as a result of presumed ischemic mechanism. Non-ischemic should be excluded. Non-ischemic, such as the pulmonary embolism, sepsis, cardiac, and volume overload, these should be excluded. So cardiac troponin must be identified within the first 30 days. Previously, it was only up to the third day, not more than that. But in the new definition, this was added that up to the MI. And but the maximum occurs after 2 days. Cardiac troponin increases up to 3 days. After that, you would need a CKMB and others to diagnose for that. Clinical symptoms and electrocardiographic changes are not required to establish a diagnosis. Previously, we were considering non-ST elevated and ST elevated MI. ST elevated MI would be the ECG changes, and non-ST we would need the cardiac enzymes. But now the criteria is that the cardiac enzymes are needed. So now another confusion, what is the 99th percentile? And there are different kits with the different markers. So this has been a new confusion raised by this definition. But they say that cardiac troponin with a high sensitivity rise should be more than 20%, and it should be 6 to 5, more than 5 and less than 45. And if there is a high sensitivity concentration, then 60, more than 65 would be considered at the MIR ischemia. So fourth generation troponin more than 30, and high sensitivity more than 20 to 65 with absolute change of more than 5 or more than 65 rise is considered as the MINS diagnosis. Now, what is the cause of the MINS? The cause is mostly the ischemic origin, and there are two mechanisms which has been identified. One is the supply-demand mismatch, and one is the pre-existing thrombus which is present, got dislodged and causes the MI. But there are other specific causes which lead this to. In the pathophysiology, when the anesthesia and surgery is given, there is a stress response. This stress response causes surge in the adrenopituitary-thalamic axis activation and the release of the hormones, such as catecholamines, cortisol, and inflammatory markers. These markers causes the imbalance between the oxygen supply and demand, and this lead to the ischemia. Another thing is that there is frequent seen the tachycardia intraoperative. This tachycardia causes hemodynamic decrease in the diastolic and increased myocardial wall stress and oxygen requirement. Episodes of hypertension increases LV afterload and increases myocardial oxygen demand. Increase in coronary artery shear stress may also destabilize thrombus. So with the thrombus, there is very less diagnosis, but others are related to the anesthesia and surgical impact on the high-risk patients which have already the cardiac issues. So the non-cardiac surgery baseline risk factor, patient has got baseline risk factor such as surgical trauma, inflation, platelet activation, coagulation, bleeding. This may cause the dislodgement of trauma which is already present in the coronary arteries. And there is other intraoperative factors. The intraoperative factors are hypertension, hypotension, tachycardia, bradycardia, hypoxemia, and anemia. This can cause the mismatch between the demand and supply and can lead to the MINS. But there are other causes which should be excluded. And those are sepsis, renal failure, volume overload. This can rise the cardiac troponin, but are non-specific for this. So the diagnosis will be exclusion of these for the MINS. Risk factors are increasing age. Previously, it was more than 65 years old, but now in the new definition, it is more than 45 years. The male sex, functional activity, and the atherosclerotic associated comorbidities, such as hypertension, diabetes, coronary artery disease, peripheral diseases, cerebrovascular diseases. Other comorbidities, such as chronic renal insufficiency, elevated rising cardiac index, and natriuretic hormones and other hormones. Now the management, the preoperative and intraoperative management. So the basic is that you should identify the risk factors and optimize them. The other is the maintain the balance between demand and supply. But what about the treatments, other treatment options which we are giving in the normal MIs? Are there any evidence for that? In the POISE trial, perioperatic ischemic evaluation trial, beta blockers showed that there was a reduction in 30% events of myocardial infarction, but there was doubled rise in the stroke and other causes which led to the mortality. And in this group, there was mortality of 3%. In this randomized control trial, 8,350 patients were included, and a metoprolol 100 mg was given. There was a POISE-2 trial which showed that the aspirin and clonidine was used in this trial, and there was no difference found in it. So the aspirin and clonidine does not affect any, but aspirin increases the time of bleeding, and there was evidence of bradycardia and hypotension during the procedures. Then there was Angima 2 trial, evaluation of nitric oxide in the gas mixture for anesthesia. The nitric oxide is neither beneficial nor any harmful effects, so it does not affect too. There is a limited data related to statins and angiotensins converting enzymes. Although the anesthesia people does not like ACE inhibitors because of their impact of hypotension intraoperative, it is refractory. But some studies show that the ACE inhibitors stabilize the clot and there is a reduction in the MIs. Then there was a vascular events in cardiac surgery and cohort evaluation VN study. This was a cohort study of 40,000 patients in which age of 45 years were included, and it showed that the statins has reduced the low risk. But this was an cohort study, so the RCTs are needed for the further. Then there was an interesting study which was called the RIPS. What was done in this? The protocol was that the 3 cycles of 5 minutes forearm ischemia was followed by 5 minutes of reperfusion. And this showed, this was done in 82 patients, and this showed that the preconditioning caused reduction in the non-cardiac MIs. But then there was a CRIPS study which showed that there was no difference. So the previous, and this was a randomized control trial, so the evidence for this study was more than the previous one. So now this preconditioning does not affect as evidence says. Intraoperative hypotension in the anesthesiology journal in 2016, there was a published of a paper which showed that the intraoperative hypotension causes myocardial increase in the myocardial injury and acute injury, even it was considered in the levels of acceptable. So the intraoperative hypotension has impact on the myocardial injury and acute kidney injuries. So the vision study also said that the tachycardia harms the patient, and it is, as we know, the demand supply of heart rate increases, it will cause ischemia. Post-operative surveillance. For the surveillance, we were using the ECGs, but now the criteria is that we may need in the high-risk patients corticotropin hormones for the monitoring. Previously, it was that the patient has got the symptoms, then we will considering that patients have got MI or not. So the CHASE trial, cardiac health after 1627 intermediate to high risk patients showed that the corticotropin hormones were increased in these patients. There is now the broad recent consensus that troponin screening is indicated for the high risk patients. Now, what are the recommendations by the societies? Canadian Society in 2007 said that there is a strong recommendation for daily post-operative cardiotroponin measurement for 48 to 72 hours, because in these time there is high risk for the MI. The European Society of Cardiology in 2014 guideline said the cardiotropin hormone 48 to 72 hours after major surgery should be considered in high risk patients. In the 2000 European Society of Anesthesia guidelines suggests considering cardiac troponin in high-risk patients both before 48 hours and 72 hours. And American Heart Association's 2014 says that the ischemic signs are symptoms but do not recommend routine cardiotroponin hormones. So the post-operative management of MINS. Post-operative management of MINS remains an area of active investigation. Still, we don't know how to manage these patients, but there was a trial of managed trial which shows that the dabigatran may decrease the events cardiac. Aspirin and antiplatelet are depend on the discrete of the clinicians. Some people start them early and says there is less chances of bleeding, and others do not. So now in the broader term, the means treatment would be the surveillance. And then if we are suspecting that there is atherosclerotic plaque disruption, then coronary revascularization or aspirin, high intensity statin therapy, beta blockers may be needed. And if it's related to the demand supply, then the treatment is non-conclusive and it's on the people's discretion that whether they want to give statins, antithrombotic or not. But the major thing will be to control the demand, to match the demand and supply. So in summary, the beta blocker decreases means but increases adverse effects and mortality. Aspirin and clonidine, no role. Statin SE inhibitors may work, need further studies, and it's up to the discretion of the clinicians whether to give or not. And prophylactic GTN has got no role in this, and control of hemodynamics is the main treatment option, and more surveillance is needed in high-risk patients for the cardiotroponin hormones would be needed for the high-risk for monitoring of 48 to 72 hours. Thank you.
Within time.
I just wanted a clear verdict of yours on beta blockers. What I thought was that if any patient is already on beta blocker and continuation of it really doesn't predispose to any added problem, and you should continue. However, are you suggesting that we start beta blocker in the preoperative period in a patient to prevent MINS?
Thank you, madam, for this comment. And this was very needed comment. If beta blockers are started 24 to 48 hours, then the events during the surgeries of hypotension are high. And but if it is already started, then there is a beneficial for those patients. And most of the high-risk patients which have coronary diseases are already on the beta blockers. The acute, previously it was the standard of care that whenever the patient admitted, the beta blocker were started in the Western world. But then the POISE trial showed that there was increase in evidence of hypotension intraoperative and the brain ischemic CVAs. So that's why now the acute start is not recommended because there is a high window of hypotension. But if the patient is already on the beta blocker, then should be continued. And if you are considering this patient is a high risk, then at least 1 week of the beta blocker should be started, and then we go for the surgery. I think it should be started a week before. Yes, 1 week. That's why I said that 1 week before the surgery. If you are considering that patient is a high risk and need the beta blocker, but in the acute, there are higher chances of the complications rather than benefit.
I also wanted your comment on the duration of hypotension. I think the duration of hypotension, intraoperative hypotension also is correlated. It's not just a spike of hypotension.
Yes. In the anesthesiology 2016, although that was related to the vascular surgeries during the non-cardiac for the MIs, but this opened the door for the other studies that we need to see that how much hypotension affects the patients. So in the high risk patients, we should put arterial line and should monitor the continuous monitoring and this swings of blood pressure, hemodynamics, up and downs, roller coaster should be not done. It should be static and should be considered in 20% range.
Mujib, thank you. Very good presentation. You did a very nice literature search. My one question is this, that what is the recent recommendation of AC inhibitor preoperatively? Previously it said that, you have to stop it the night before, skip the morning dose. Ab recent kya hai iski, because you have gone through so much of literature?
There is still not any evidence of much studies available for the AC inhibitors that whether we need to stop or not. But the AC inhibitors causes the hypotension. If some clinician stop it, some clinician decrease the dose, and some
recent recommendations, guidelines.
There is currently no recommendation.
अच्छा, और आपने जो society की जो guidelines बताई for troponin, right? Yes. I think all of them are recommending giving, doing troponin in high-risk patient except for the last, the
Because
American
it was
guidelines?
2014's recommendation by the American Society, and probably the newer guideline would change it for the surveillance.
But what like all guidelines are saying that in a high-risk patients, you do prophylactic and troponin without any signs and symptoms or?
Yes. That's what I said in the management of that when the patient have got ischemia, it does not show any symptoms because we have already given them huge amount of analgesic, so that it will not produce the chest pain. There is a transient change in the ECG, and we are monitoring only 1 or 2 leads. We are not monitoring the 12 lead ECG.
So recommendation is to do.
Yes, previously it was that the chest pain or symptoms of the patient with the troponin if needed high risk patients. In the ST and non-ST elevated MI and the chest pain have patient go, or there is some problem, dyspnea or a functional class has been changed, to aap karate the. But now in the all high risk, it has been recommended that up to 24 to 48 hours, the troponin should be done in the series. And if one is rise, it is considered as means.
So one question from my side that what do you suggest, what is the guideline about using prophylactic dose of anticoagulants in high risk group and patients going for some vascular surgical procedures?
Anticoagulants does not affect much. Only in one study which has got shown that the dabigatran has impact. The problem is that if we are using the anticoagulants, there are high risk of the bleeding. So we are doing the high risk surgeries, and we are like open surgeries would be have a high risk of bleeding. So it should be balanced, and that anticoagulants are not currently not recommended for this, because the major pathophysiology behind the means is demand and supply, not the atheroma dislodgement. In the longer run may have impact, but in the acute setup, it has got no effect. Okay, thank you.
Okay, thank you very much, and very nice talk. Not The next speaker is Dr. Vinod Kumar. He is consultant anesthetist, Department of Anesthesia and Critical Care at the Indus Hospital Network. He is going to talk about enhanced recovery after surgery, win for both administration and patient. Dr. Vinod.
Hello, everyone. My name is Dr. Vinod. I'm working as a consultant anesthetist at the Indus Hospital, Karachi. The topic on my presentation is enhanced recovery after surgery. Basically, the time to change practice. I have no conflict of interest. Sorry. The concept of ERAS was first given by a surgeon, Professor Henrik Elth, in 1990. What was ERAS? ERAS is the standardized protocol for preoperative care. It includes multimodal intervention, reduce operative stress, support organ function, reduce morbidity, and accelerate the convalescence. You can see in this picture when the red marking shows when the ERAS is implemented in fund studies, that recovery was early as compared to traditional care. The ERAS other names include Enhanced Recovery Program, Fast Surgery, Optimized Perioperative Care. These are the other names of ERAS. ERAS key component include active patient involvement in all stages of the surgery. It includes preoperative, intraop, and postoperative. Preoperative component include preoperative admission of the patients, early discharge criteria, carbohydrate loading, reduced fasting duration, venous thromboembolism prophylaxis, antibiotic prophylaxis, pre-warming. The intraop component include active warming of the patient, use of multimodal analgesia. Surgical techniques should be changed. Avoid prophylaxis, NGA tubes, and drain. In the post-operative care, early oral nutrition should be started, early mobilization should be started, early removal of catheters, follies, and use of chewing gum is very much famous in ERAS. Then should be first patient is admitted, he should be defined discharge criteria. Use of multimodal antiemetics in pre-op, intra-op and post-operative periods. And one should include the audit and compliance and outcomes, the whole team involvement. Basically, ERAS is a whole team involvement. There are basically three approaches: surgeon approaches, anesthesia approach, and protocolization. In the ERAS pre-operative component include, just I discuss, we will discuss one by one. The pre-operative information. The pre-operative information include pre-admission education and counseling of the patient. It will decrease the fear and anxiety of the patient. It may reduce the perivalence and complication. It may reduce and leads to enhanced post-operative recovery and discharge. The next is health and medical optimization. Patient should be optimized before the surgery. He should be increasing exercise, and preoperatively walking and training program should be included in ERAS. What will implement the preoperative involvement of is may increase the psychological function and physiological function. Walking may easier to implement, psychological preparation and motivation for the patient. And in preoperative period, smoking should be stopped 4 weeks before surgery. The nutrition. Undernutrition patient maybe malnutrition patient may lead to morbidity, increase the chances of wound healing, infections, and complications. Convenience may lead to mortality, treatment increase, and length of stay should be increased. Okay. And preoperative fasting, the standard practice was fasting from midnight, reduce the volume and acidity in the stomach, decrease the risk of aspiration. That was previously thought, but modern fasting guideline clear fluid 2 hours after the surgery. These are the research for unus anesthesia. Surgical stress. Surgical stress is basically leads to inflammatory response that leads to anesthesia complication, and endocrine response may be raised. It leads to catabolism, hyperglycemia, and organ dysfunction. It may leads to raise in the insulin resistance. When the insulin resistance is raised, then 5 to 6-fold increase in the patient risk of complication and 10-fold risk of infection. How can we reduce the insulin resistance? By carbohydrate drinking in the ERAS component. We can give 12.5% carbohydrate drink to 400 ml before the surgery. Incidents may reduce insulin. Don't worry about aspiration. There is a study in 1995, gastric emptying is complete in 90 minutes, and carbohydrate and water, and many more studies are present for killer fluid. Effect of the perioperative carbohydrate. What the carbohydrate do? Carbohydrate reduce the metabolic stress to surgery, effectively reduce the insulin resistance, improve the preoperative well-being, improve the post-operative well-being, and reduce the lean body weight masses, may result in faster recovery. The other component is pediatric medication. The medication include no sedative medication before surgery. Patient educate the patient, avoid starvation and carbohydrate loading, and short-acting IV opioids or spinal or regional may be benefited. Preoperative ERAS component include antithrombotic prophylaxis, as we can use mechanical for compression and intermittent pneumatic devices, and pharmacologically we can use low molecular heparin. The intraoperative component include antimicrobial therapy. Antimicrobial therapy should be started 30-60 meters before the incision, and we can use anesthesia protocol for target rapid awake the patient. Target was the rapid awake the patient. Anesthesia technique should be balanced anesthesia and DIVA. Short acting anesthesia, short hypnotic prophylaxis, analgesics, sufentanil and remifentanil should be used, and multimodal analgesia should be planned. For epidural analgesia and peripheral nerve blocks, we can use, and when we use pain buster also in this. Benefit of epidural anesthesia: dynamic pain control, optimal response, reduction of the LES, reduce the post-operative pulmonary complications, and reduce the myocardial ischemia, and it will reduce the DVT and prophylaxis. We can avoid the post-op vomiting by a multimodal approach by pharmacological and non-pharmacological technique, and avoid techniques. We can avoid by TIVA, minimal fasting, carbohydrate loading, adequate hydration. These all lead to decrease post-op vomiting after surgery. The perioperative fluid management should be vasopressor included, types of fluid should be crystalloid and should be goal-directed fluid therapy. Hypothermia include may risk of wound infection, so we can prevent hypothermia intra-op and post-op as well. Wound infection, prolonged sedation and cardiac event can happen. Shivering may increase the oxygen consumption and bleeding, coagulation disorder and thrombotic dysfunctions. Post-operative component of ERAS. We can use post-operative anesthesia. We can use multimodal anesthesia, good pain relief. That leads to reduction in cardiovascular, congenital endocrine function, decrease in risk of chronic pain, allow early mobilization, allow return of gut functions. The fluid management leads to reduce the 59% risk of complication and 3.4% average delay in the reduction of the hospital stay. Post-operative nutrition. Post-operative nutrition should be start on the first very day post-operative, and should be maintained, not before traditional care. You should start only 24 hours, 48 hours only liquid, right? Early mobilization affects early return of gut bound, improve digestive function, enhance anabolism, decrease the risk of venous thromboembolism, and enhance the recovery. And condition include good anesthesia, ventilatory support. The post-operative should be like this. Surgeon approach. Traditional care versus evidence-based medicine. On the day of surgery, try to stop IV fluid, allow oral, start oral drinking, regular preemptive antiemetics, early mobilization as soon as possible. On day one, urinary catheter should be removed on the first day, and 8 hours before the surgery. Presume normal diet, preemptive oral analgesic should be started as soon as possible. On day two, epidural infusion should be stopped in the morning. Epidural catheter should be removed if the colonic surgery happen. On the discharge criteria, on the 3-4, you can discharge patient GIT function, able to eat and drink without discomfort, passing flatus. Discharge rate is important target for the patient, and stop but flexibility is vital. This is for colonic surgery. I want to discuss few randomized meta analysis. In this ERAS clinical outcome reduced complication by 50%, 6 RCT studies. And 6 RCT for short the length of stay, 2.5 days average. And preoperative oral carbohydrate hoarding and preoperative less NPO, significant independent predictor of the improved clinical outcomes. Basically, the win-win situation for both administration and the patient. For rapid recovery, team benefits, optimize preoperative admission, easier to move, better educate the patient. For rapid recovery, according to surgeon benefit, he may more operation, less infection, greater efficiency, more satisfaction. For the trust benefit, more positive press, reduce the complication, increase the turnover of the patient. And for the patient benefits, you can produce education, may go to home early, family commitment, and quicker return to the desired home. How can we implement ERAS in protocols? Select a target, invite a participant to create a team. Explain what are we doing, try to achieve. Select an expert group. Create a change in concept and provide, implement strategy. A regular review to measure the evaluate the changes and review strategy. The team members of ERAS include nurse, dietitian, physiotherapist, occupational therapist, pain, anesthetist, surgeon, hospital management, and audit team must be present. When the patient admit in hospital, you can give a brochure just like day 1, what will you do, day 2, what will you do, day 3, what will you do. Patients are now prepared, warm, stronger, out of the way, mobilized, hydrate, little complaining about small thing. Enhanced recovery after surgery, efficient way to help patient got better recovery. There is nothing new under the sun, but there is a lot of old things that we know or know. Thank you. Thank you.
One question from my side.
Yes, ma'am.
As you told about that in ERAS is a multidisciplinary and multimodal approach to patients who are undergoing surgical procedure, especially the colonic surgeries.
Yes.
And the one of the component of this program is carbohydrate intake preoperatively,
Yes, yes,
8
ma'am.
hours prior and 2 hours before
Before surgery.
induction. So what do you suggest for the patients who is coming, who is diabetic and history of gastroparesis? So we still give,
Yes, ma'am, we can still give because we have to control sugar level below 200. Okay, monitoring, and we can give them little amount, the 12.5% we can reduce to 6.25%, or we can in our setup we can use glucose D's, just like to reduce the concentration of carbohydrate. But there is no risk of aspiration. We are already planning our diabetic patient on first on list, so we can manage this problem.
any question from the,
Thank you. Thank you.
thank you.
Thank you. So for the next talk, I'll ask Dr. Arshi Naz to please talk about management and prevention of CLABSI, central line associated bloodstream infections. Dr. Arshi Naz did her FCPS in 2013, currently working as assistant professor in anesthesiology at Shaheed Mohtarama Benazir Bhutto Trauma Center. She had a leading role in setting up the running COVID units during the pandemic. She is currently working on SIN Trauma Registry Project at trauma centers and other public sector tertiary care hospitals of SIN. Welcome.
Thank you so much, sir, for such a wonderful introduction. So I'm Dr. Arshi from Trauma Center, and I will talk over the management and prevention of central line associated bloodstream infection. These infections are sometimes quite challenging while working in ICUs, and a multidisciplinary like approach is used, like anesthetists, ICU doctors, staff, and the infectious disease personals are also involved in this situation. So I will try to cover the impact, cost, and morbidity mortality associated with CLABSI, and the definitions as per CDC guidelines, and a tiered approach to prevent CLABSI. So I will use references from these different societies. So I've given the full form here. So there are two definitions as far as CLABSI is concerned, and it's always a source of confusion, because CDC explains the surveillance definition, and then there is another definition that is the clinical one. And surveillance definition is basically which shows the trends in population, and it's for data gathering purpose, while clinical definition is the one which we apply on the patient, we manage and treat according to that. So according to the surveillance definition, recovery of pathogen from blood culture in patients who had central line at the time of infection or within 48 hours before development of infection. And the infection cannot be related to any other infection of the body. This is according to the CDC guideline and NHSN database. Like, just to simplify it, if patient has a line placed on June 1 and he becomes febrile on June 3 and central line is in place and the culture is positive from central and peripheral both sources, then it will be labeled as CLABSI. This is according to the surveillance definition. And similarly, even if the catheter is removed and patient is febrile next day and the culture is a positive for the same organism, still it is CLABSI, because removal is not, like 2 days are not passed before the removal. Then comes the clinical definition that is more relevant and that we apply while managing patients in ICU. 3 criteria has to be fulfilled. You're changing something. three criteria has to be fulfilled. First, patient has to have clinical signs of an infection like fever, rigors, altered mental status, or low blood pressure. Secondly, there should be no alternate source of bloodstream infection. And the third, any one of the following. Catheter tip culture that matches the organism grown from the blood, and at least 3-4 higher number of organisms grown from the catheter versus the peripheral blood culture on simultaneously drawn culture, or the at least 2 hour quicker growth of organism from the central line culture. This is the definition by Infectious Disease Society of America and Society of Healthcare Epidemiology of America. So, in short, whenever we have positive blood culture, there can be 3 possibilities. It could be colonization or contamination, it could be secondary bacteremia, and it could be central line associated infection. For labeling it central line associated infection, we have to have quicker or more growth of organism in the culture taken from the central line. Now, before moving forward, like we have to differentiate between the colonization and the actual CLEP-C infection. So colonization is the presence of more than 15 colony forming unit on a quantitative culture without symptoms and negative blood culture. So why it is important to study so much about CLEP-C? Because it prolong hospital length of stay, increase morbidity and mortality up to 12 to 25%, and they are costly also. And it is an estimate that it can increase a cost of 48,000 or even more per episode. So there are huge data available for incidence, ratio, and risk factor for CLEP-C, like in the Western world. But I'm trying to quote some local research papers to reflect the burden of CLEP-C in our population. So this is a study conducted in Islamabad, the tertiary care hospital, where they found that most of the CLEP-C positive bugs were Coagulase negative staph, and rate of infection was 12.9%, which apparently matches, which is quoted in CDC statistics, that is 12 to 25%. But there were some limitations in this study, so we might not have the like accurate data. This is another study from a developing country, and it's a very interesting study in which they find out the risk factors also, which is like a prolonged ICU stay days itself is a risk factor for developing CLEP-C, and then higher Apache score and the number of CVC days. And in their setup, 7.9 per 1,000 central line days was the ratio. This is again a surveillance definition of the rate of central line infection. And then this is a study conducted in Pakistan, a private tertiary care hospital, and they states CLEP-C reduction using evidence-based intervention and nurse empowerment, a quality improvement initiative from a tertiary care and ICU in Pakistan. And they said that by applying some CLEP-C prevention package, rate decreased from 17.1 to 5. So to target the prevention effort, we should know the pathogenesis. So there are 4 routes of transmission: extraluminal, intraluminal, secondary bloodstream infection, and infusate contamination. So you can see that improper insertion technique can cause migration of pathogen through skin to the outer surface of the catheter. And intraluminal is because of hub contamination. Without proper cleaning, if we give drug through the hub, it can also cause CLEP-C. And then the culprit bugs are in gram-positive, mostly Staphylococci, Enterococci, and in gram-negative, Klebsiella and Enterobacter. But these are all from the Western world, and we should have our own microbial spectrum affecting our patient. So risk factor, very well defined by CDC, the patient, provider, and device factor. In patient characteristic, apart from other factors, prolonged hospital stay prior to device placement, that is central line placement, is also a risk factor. And provider characteristic, emergency insertion, excessive manipulation, and one very important aspect which we face in public sector setups is low nurse to patient staffing ratio. So the catheter hub care is not appropriate. So obviously, when there is low nurse to patient ratio, nurse will be multitasking, dealing a lot of things along with these infection prevention strategies. So there might be a compromise. And then device characteristic, like selection of the site and number of lumen, and the indication for which CVP is being used. So how to prevent? Michigan Hospital of America, they did a keystone study based on 103 ICUs, and they launched in October 2003, and they use a bundle of best practices, which is based on simple basic precautions: keep sterile and prevent clepsy. And after this, they conclude that before these bundle application, the rate was 2.7, or agar mean le to 0.6 to 4.8. Then during implementation, it reduced to 1.6, and then gradually it reduced further. So they form a checklist for proper insertion, and they develop maintenance guideline, which we all are familiar. It comprised of basic antiseptic measures, hand hygienes and site selection, chlorhexidine cleaning, and sterile gauze dressing or sterile transparent dressing over the insertion site. There is also recommendation of using chlorhexidine impregnated dressing unless the facility is demonstrating success at preventing clepsy with baseline prevention practices. Same with the maintenance bundle, in which change gauze dressing every 2 days, of semi-permeable. Agar gauze dressing hai to change every 2 days, and transparent as soon as it get wet, soiled, or dislodged. And if continuous infusion are running through the clepsy, especially fat emulsions or propofol, so they have different guidelines. So bug off means scrub the hub for 15 seconds and let it dry for 15 seconds. It is seen that clepsy rates decreased only when units had bundle policy, if they monitored the compliance and demonstrated more than 95% compliance. Now, these are the tiered approach for the management and prevention of clepsy. In tier 1, there are some basic measures that are discussed in the bundle approach. In tier 2, like tier 1 are those interventions best supported by the evidence that are effective in preventing, and these are the basic bundle points. And in tier 2 is composed of intervention. If after following tier 1 and after auditing of tier 1 approaches, and hospital is fulfilling the tier 1 approaches, and even then if hospital is not able to control clepsy, then tier 2 interventions are recommended. But they are more complicated, more costly, but could be helpful to prevent clepsy. So once clepsy is diagnosed, catheter removal is recommended, parenteral antibiotic, then will come the role of infectious disease doctor, and like mutual decision of anesthetist and infectious disease doctor that which antibiotic according to culture and for how many days it should be run. So in tier 2 approach, as I said, there are some recommendations, mostly on education, auditing, documentation, and then check, recheck. And there is additional approach for antimicrobial or antiseptic coated CVC. So what are these? These are the CVP central lines which are coated with some antibiotics like minocycline and rifampicin, or some antiseptics like chlorhexidine or sulfadiazine. They can be both internal and external coating. And what they did, they prevent the formation of biofilm, or they remove the reversible biofilm from the lumen of central line, which is the cause of disseminated infection. And there is not from the CDC, but there are some recommendations that antibiotic lock therapy can be used, in which 1 ml of Vanco, 5 mics per ml, and 0.5 ml ceftazidime and heparin just filled up and flush the port. They will remove the biofilm if it is in reversible stage and prevent clepsy. So this is the biofilm which is considered as the culprit, in which pathogens initially they are reversibly adhesion, and then irreversible, and then fibrin sheath is formed around them. And they help the pathogen to survive, and they prevent the penetration of antibiotic to their coating. These are some studies which favor the use of coated CVPs, but again, it is the recommendation in the tier 2 approach, which is said that after fulfilling appropriately all the basic precautions, a hospital is not able to overcome clepsy, then only we can go towards that. But only few studies proven its role. So take home message is engage all the personnel who are involved, educate, re-educate, and then execute the bundle. Can be the CDC bundle and can be institutionalized, and then evaluate. Because the thing which we cannot measure, we cannot improve, or we cannot correct. Thank you.
Thank you very much, Dr. Arshi. Any question or comments from the audience? I have a little question to ask you, or maybe a recommendation, that out of this whole lecture, considering our status of third world country, if we ask for, let's say, the antibiotic coated lines and all that, that might not be so practical for all people. What new trick or thing you will ask us or tell us that this works the best? For example, like initially preparation, you are already ready. Then whenever you change the, or whenever you use the line, what few steps would be best? Like, for example, what I got from you, this was that initially they were using a heparin lock just to prevent it from clotting. But if we add this combination of an antibiotic and a heparin, that might be a useful thing.
Yes.
Economical and practical. Yes. I hope people will agree with me.
Yes, it
well,
is.
Along with the other things, of course.
It is economical, but still I didn't find it in the guideline of CDC. But the thing which they focus is the insertion technique. So the proper education, training, and then checking, auditing, and then feedback is very important, because they mention that like check the compliance, and if compliance is more than 95%, then they can control. And another thing is the scrub the hub. They focus on that a lot, that before giving anything, 15 seconds of scrubbing of the hub, then 15 seconds for drying, and then it can reduce the rate.
Yes, but my idea is that probably the infection gets in by later handling of these centralized. Initially, you are prepared, you're scrubbing and doing everything.
Yes.
But then when they later on for different injections, all that, that is the time when the infection gets in.
Yes.
So
yes,
usko prevention.
Yes.
Thank you very much. This is a very interesting talk.
Thank you. Thank
you. So the next speaker is Dr. Anam Mughal. She is going to talk about a new trend, that is segmental spinal. So she's working as a senior registrar, Department of Anesthesia, Civil Hospital, Karachi. And she's a very promising student, Board of Intermediate Education gold medalist, got second position oral presentations in PSA 2018 as a resident. Excellent. Please.
Thank you. Thank you, sir, for such introduction. Assalamu alaikum. PSA, thank you for giving me the opportunity to come and stand here in front of you at the 40th annual conference of Pakistan Society of Anesthesiologists. I'm Dr. Anamawal. So today I'm going to discuss about thoracic segmental spinal anesthesia. It's a technique of regional anesthesia that can potentially be suitable alternative to general anesthesia. And it can be done in surgeries such as laparoscopic cholecystectomy or mastectomies. Although we as an anesthetist are not used to it, the procedure, but this procedure has been shown in beneficial maintaining hemodynamics of the patient, especially for those patients who are with extremes of morbidity and My activity describes the procedure of thoracic segmental spinal anesthesia and explains the role of interprofessional team management who have undergone this procedure. So today's objectives are patient selection, anatomy and physiology of thoracic spine, its complication, and managing the patient as a team. Thoracic segmental spinal anesthesia, it is typically utilized for patients undergoing surgery with major medical problems, for whom general anesthesia is not recommended. Drawbacks, which includes negative drug side effects, prolonged recovery time, inadequate pain control. There is currently renewed attention towards thoracic segmental spinal anesthesia for several common surgeries. Injection of anesthetic intrathecally into the preferred body height and above where the cord terminates has been revealed to be valuable in these certain circumstances. However, anesthetists are hesitant to perform spinal anesthesia above the termination of conus medullaris for the fear of injuring cord. But thoracic spine anesthesia has been demonstrated as a safe and effective method for various surgeries, including laparoscopic cholecystectomies, breast lumpectomies, and abdominal cancer surgeries. Now reviewing a little about anatomy of the thoracic spine. As you can see in this MRI image, the mid to lower thoracic segments of the cord lies anteriorly, where there is a greater depth of the posterior subarachnoid space in the thoracic spinal cord. However, the spinal cord and the chorda equina at the lumbar region are touching the dura mater posteriorly. Reviewing the gross anatomy, as you all know, in thoracic region, interlaminar spaces are narrower and the spinous processes of the thoracic vertebra points inferiorly, versus the lumbar vertebra, whose spinous processes point posteriorly and the lamina does not overlap. Now I'll highlight a little of physiology. As in thoracic segmental spinal, a small number of nerve roots are covered by anesthetic agent within the subarachnoid space. So it provides necessary anesthesia in the surgical field dermatomes. Further, since there is a less of a lower extremity blockage, a larger portion of the body does not experience venous dilatation, which ultimately compensates for blood pressure. Talking about the indications, thoracic segmental spinal anesthesia is currently best suited for selected procedures and patient population. It is used in high risk of perioperative morbidity and mortality, where under general anesthesia, individuals can go in decline physiological reserves with multiple comorbidities, having polypharmacy and cognitive dysfunction and frailty. Other than that, the surgical procedures which can be performed under it are abdominal cancer surgeries, breast cancer surgeries, and laparoscopic cholecystectomies. Contraindications are not new to all of us. They are all those contraindications which are of neuroaxial anesthesia. Absolute and relative, that is lack of consent, local infection at the site, drug allergy, raised ICP, or greater operative time. And relative includes any neurologic deficits, sepsis, severe hypovolemia, coagulopathy, severe MS, and AS. Discussing about the technique, the initial setup for the procedure is patient positioning, which is performed either in sitting or lateral decubitus position. The positioning also includes the height of OR table, providing blankets for comfort and sedation for the patient if required. Sitting position is commonly favored because it avoids a potential rotation of the spine that occur with lateral decubitus position. The patient should flex the neck and push out the lower back to open up the thoracic intervertebral spaces. For the lateral decubitus position, the ideal positioning consists of having the patient's back in line with the edge of the bed closest to the anesthetist, with the patient's knees flexed up to their abdomen. Preparation includes identifying your patient, taking detailed history, physical examination and excluding any scoliosis, previous surgery or infection, severely restricted range of motion, and basic neurological examination for gross motor and sensory deficits. And furthermore, lab studies and vital signs. After preparing the patient, the next step is space identification. The insertion level is identified either by palpation or the use of ultrasound guidance. By palpation method and the use of anatomical landmarks to identify the corresponding spinous processes, the inferior angle of the scapula that correlates with the T7 spinous process and the 12th rib margin that correlates with the L1 spinous process. And another approach is to use ultrasound guidance with the counting up method starting from the 12th rib. After space identification, the next is about the approach. Either the anesthetist use midline approach, paramedian approach, simple spinal or combined spinal epidural. In the midline approach at thoracic region, the needle is angled more carefully because of the long thoracic spinous processes that points inferiorly and caudally, and they are most sharply angled between T4 and T9. While in paramedian approach, the spinal needle advances at an angle towards the midline. In this approach, the supraspinatus and interspinatus ligaments are not encountered. So there is less resistance before reaching the ligamentum flavum. The third one and more easier approach is combined spinal epidural that can be used first to identify the epidural space with loss of resistance technique, followed by advancement of a spinal needle through the epidural needle. The combined spinal epidural system can limit the amount of needle that projects beyond the tip of the epidural, further minimizing the risk of cord injury. Now, drug dosage. So in thoracic segmental spinal anesthesia, as we are just blocking limited number of segments, approximately 50% of the dose is required from conventional lumbar spinal anesthesia. Surgeries can be done in 1 to 2 ml of 0.5 to 0.7% of bupivacaine with addition of adjuvants such as fentanyl. Hyperbaric and isobaric both can be used. Equipments. It should be performed as an aseptic technique. Monitoring of ventilation, oxygenation, and circulatory system is mandatory. IV access should be established. Spinal anesthesia kit be available. And the most common drug used is bupivacaine. Complications are not new to all of us. Direct needle trauma, infection, abscess, meningitis, vertebral canal hematoma, or spinal cord ischemia, erycoiditis, total spinal, cardiovascular collapse, and death. All can happen. Now, who should perform this? As this is a newer technique and it should be performed by experienced anesthesiologists who have extensive practice with neuroaxial anesthesia. It is recommended that thoracic spinal should be performed by highly experienced anesthetists who are comfortable performing this procedure. Additional support from other staff members such as additional anesthetist, nurse anesthetist, and nursing staff are also necessary. The other team members are present to assist with equipment and supplies. In addition, the patient needs someone to ensure that they maintain their posture and keep them safe in their position on the OR table. The clinical significance of thoracic spinal, segmental spinal anesthesia, I'm going to discuss. It offers many benefits not available with general anesthesia or with lumbar spinal in some cases. This technique has made it possible to perform certain major operations on an awake patient who are at high risk of morbidity and mortality under general anesthesia. Other benefits include better pain control than opioids and a decrease in opioid requirement during or after the procedure, which lowers the incidence of the side effects with these drugs. Furthermore, there is earlier recovery of bowel function and decreased complication, which results in a shorter length of stay in hospital. This procedure can also be valuable for post-operative pain relief in combination with other modalities. Lastly, the anesthetic dose is lower, so hemodynamic instability becomes minimal. Administering thoracic spinal anesthesia may also allow for the potential surgeries that cannot be performed with other specialties, such as those that needed a prolonged hospital course can also occur with high risk of patient and can be done safely. To enhance healthcare team outcomes, awareness is key. So thoracic spinal anesthesia, it is beneficial that it is useful for a wide range of surgical procedure. However, there are significant risks that the healthcare team needs to be aware of. Patient selection is an important aspect, and a detailed history and examination will determine who is eligible. The indication of thoracic spinal anesthesia needs to match with surgical needs of the patient. After surgery, the post-op team should be aware of the procedure, and the patient needs to be monitored closely for hemodynamic stability. Monitoring in the immediate post-operative period should occur until the resolution of the anesthetic agent. Both physicians and nurses from other specialties should also be aware of the nature of anesthesia given to the patient. Before discharge, the patient should receive a list of possible complications and look out for them. They should be asked about any headaches, backache, and evaluated for neurological deficits. Lastly, the patient should be reassured and re-evaluated regarding any complication that may have occurred from this procedure. Thank you.
Thank you very much, Doctor. Any comment? Dr. Khalid Bashir, please.
Thank you for the very recent advances.
Thank you, sir.
There are certain questions.
Yes.
How can you ensure unilateral? It is recommended for unilateral.
Sorry, sir?
It is recommended for unilateral anesthesia, not for bilateral. Okay.
That it could be unilateral and not bilateral. बंद हो गया सर.
Hello.
How can we ensure that it is unilateral effect? अगर bilateral होगा, आप lab को ही बात की आपने, तो it will always be bilateral anesthesia, not unilateral. So segmental block means you are blocking only certain segments of spinal cord.
Yes, sir. We are blocking only certain segments, but they are bilaterally. They are not unilateral.
So, but I want to say that we have been doing this for cancer patients. Segmental block of CA breast patients, or even malignancy of the thighs unilateral. So उसमें हम ये करते हैं कि हम we inject at certain dermatome level. If you want to block T4 to T7 or T8, so 0.2 ml covers usually one segment.
Yes.
And we have to give about one. If you give 1 ml unilaterally heavy, again it will cover only 4 segments, 4 to 5 segments, which will be sufficient for cholecystectomy, open, not for lap chole. So lap chole mein you need to cover bilaterally. Abdomen pura distend ho jana usme.
Yes, sir.
So it won't be useful for lap choles. Yes, it can be used for open cholecystectomy, provided to use heavy bupivacaine in lateral position. You can't use segmental in sitting position. सारा सेटल डाउन कर देगा. कोई L1 पे आप सेल कट ब्लॉक खत्म हो जाती है, सारी रूट्स वहां से निकल रही हैं. Even if you inject at T12, T7 level, तो सारी transaction हो जाएगी नीचे तक सारी, तो segmental नहीं होगा फिर ये. So it has to be unilateral.
No, no, sir, it doesn't have to be unilateral. Basically, the concept is that you are sparing the cervical and the lumbar and upper thoracic
Lumbar
vertebrae.
cannot be spared. If you are using heavy BP again in standing position, you cannot spare lumbar.
Sir, in segmental spinal, we only use 0.5 hyperbaric, and this procedure has to be done with an isobaric drug to keep the drug at its original place. While using isobaric drug, using minimal dose of 1 or 1.5 ml, we can cover up till 7-8 segments, and our surgery can be done in that. Okay, the indications are very limited till now. The data has been suggested for laparoscopic cholecystectomies and mastectomies only, just 2 indications. And in them, the anesthetists around the world, they are using 1 to 2 ml of isobaric bupivacaine, not hyperbaric. If they want some more extension of to cover the dermatomes level, then they only add 0.5 of hyperbaric bupivacaine, not more than that.
Thank you.
Basically, the segmental was on the BJ में एक जो आर्टिकल छपा था उसके बेसिस पे सारी दुनिया segmental के पीछे पड़ी. लेकिन as sir said, lateral में ही लगाया जाता है, एक ही तरफ होता है. आप अगर बिठा के लगाएंगे तो नीचे बैठ जाएगा. तो आप भले आप isobaric use करो. एक. The second thing is that what is the advantage of giving the segmental block versus general anesthesia in those patients which you are going for the lap chole? What is the difference? You are taking a risk for segmental.
Yes.
And there are chances, 10% chances of the injury to the spinal cord because there is only 1 to 2 mm space where you are putting the needle. And what would be the advantage in the lap chole? In the cancer patient, yes, there are multiple studies which says that in the general anesthesia, there is a problem that these you can metastasis. क्योंकि जो कैंसर है वो ज़्यादा फैल सकता है for the in the general anesthesia. That's why it started के spinal जो है वो segmental में कम hemodynamics होते हैं, thoracolumbar आप outflow को नहीं बंद करते. What is advantages in lap chole when you are going for general anesthesia versus in the segmental?
Okay, so your first question was that why we are doing thoracic segmental because of the risk of cord injury. So
in elective laparoscopic procedure in the patients which are cancer patients, okay. But in the laparoscopic portion, what is the advantage of segmental versus general anesthesia? What is the difference?
Okay, so here it's actually basically a new trend that has been introduced into the Society of Anesthesiologists. Conventional general anesthesia is available to everyone, and everyone is expertise in giving general anesthesia. But segmental spinal, the point is that as it is a new procedure and they are developing it and making its new recommendation. So that is why we are not currently studying it in our textbooks. We can only find it on the internet in research articles because the things are still going on and risk and benefits are still on its way to be found out by the anesthetists who are performing such procedures. But what they have recommended that such patients who are not ASA 1 and 2 and they are undergoing laparoscopic surgeries, who are ASA 3 and 4, they can be done under segmental spinal, not general anesthesia.
Thank you very
Just
much.
because of the concern of post-op recovery and post-op ICU.
Thank you very much.
Thank you,
That's
sir.
good. For the selected patients, I think this is a new technique that can be used. So this brings us to the end of the session, and I think now the presenters need to have their certificates, and please announce so that they can come.
Dr. Mujib Kumar, please come on stage for collecting your certificate. Mujib Ahmed. Dr. Mujib Ahmed.
Not Kumar.
Mujib Ahmed, yes. Dr. Vinod Kumar, please come on stage for collecting your certificate. Dr. Arshi Nas. Dr. Anam Mughal, please come on stage for collecting your certificate. And I would like to request Dr. Jodat Salim to, sir, please come on stage for giving the certificate to our chairs for the session, Professor Ismat Wasim Chaudhary and Professor Fawzia Ali. Thank you, sir. All right, moving on to our next session. This is the third session, anesthesia as of 2022. The chairs for this session is Professor Madhiya Ashmi from Ziauddin Medical University. She is the chairperson of critical care medicine at Ziauddin University. She is also the founder of Pakistan Registry of Intensive Care. Her special interest is in critical care area, especially in Sepsis Alliance. Please round of applause for her. And I would also like to request Professor Amjad Ali, sir, please come on stage. Sir is professor and head of the anesthesia department of Bolan University of Medical and Health Sciences, Quetta, holds second fellowship in cardiac anesthesia from Malaysia. Thank you, sir, for coming.
Hello, Assalamu alaikum everyone, and congratulations to the organizing committee for getting us all together again and giving the juniors this opportunity to be part of such informative talks. So this is the third session of the 40th PSA conference, and I would like to invite our first speaker, but I haven't seen him, Dr. Ehsan Wakar. Okay, so he's here. It's hard to miss him, but I didn't see him. So Dr. Ehsan Wakar is medical director, consultant anesthetist, anesthesia and critical care at Shaukat Khana Memorial Cancer Hospital, Lahore. And his interests are difficult airway, upper GI and thoracic anesthesia. And today he's going to present about opioid sparing anesthesia and innovative.
While they set it up, I'll start off. Assalamu alaikum. My name is Ehsan, as introduced by Dr. Madhiya. First of all, my congratulations to the organizers for having organized this conference, because I think this is the first physical conference we've had in the last couple of years. So this is a major landmark in that context. And thanks very much for inviting me. So what I'm going to do today is talk about opioid sparing anesthesia. Otherwise, they're still. So I can now start? Yes, okay, fine. Right. So we, human beings love opioids. We've been in love with opioids for the last 8,000 years. If you Google who has used opioid or abused opioid, the who's who of the history of the world will appear in that list. So we've been using it for 8,000 years. In medical science, we started using it since 1850, so a good 150 years. It has always been trendy. When I was growing up in Islamabad, 1980s, it was very trendy to use heroin. And one of our neighbors, who was 16-year-old, who was probably considered at that time as one of the fastest bowlers in Pakistan, he died of heroin overdose. So this trend has been there. In medical fraternity, we don't really go for trends or fashions. What we like to believe is that we will follow evidence rather than fashion or the trends. We got a recent trend, which is opioid-free anesthesia. We love talking about it. And from opioid-free anesthesia, there's a shift, there's a slight trend towards completely eradicating opioids in our anesthesia practice. And this is what I'm interested in. Is it good or bad? Are opioids good or bad? Most of you have seen this movie. Some of the younger ones may not have. So there's a very famous movie, The Good, the Bad, the Ugly. These are all killers. They are very efficient at what they do. They are very good at what they do. They are very potent killers, but they are killers, mind you. Despite the fact that they're all killers, they're still labeled as good, the bad, and the ugly. And the same sort of a concept I would apply to opioids, that opioids, yes, they have their problems, and you can classify them as good, bad, ugly, but opioids are potent analgesics. What are the advantages? It remains one of the arsenal that we have as an anesthetist. This is something that we use every day. These are potent analgesics. Let's not forget that. They still form the backbone of chronic pain management. And we have a long history. We know them since 8,000 years. We exactly know what opioids do. We know all the pharmacokinetics and the dynamics. We are familiar with it. There is nothing unfamiliar with opioids that is out there. We don't have any surprises anywhere. What are the disadvantages? There are obviously unwanted side effects. One of my neighbors died. I know that for sure. There is addiction. There is tolerance. If we write obituary of opioids a few years down the line, this would be a watershed moment. 2019, United States published that there are 70,000 deaths. And they attributed it and termed it as opioid epidemic. There are two things that we must understand about this. So this is something that is very often quoted, this study. Remember, this is in United States where opioids are available everywhere. This is not the case in Pakistan. Number two, this is not about opioid use in anesthesia or ICU. This is about opioid abuse. This is about opioid abuse out of hospital setting. So we must be very careful while we try and interpret this information. So there are three distinct times that we understand that opioid use increased. The first was 1960 when we actually started using then propoxyphene was the first drug that we started using, followed by 1999 where we started using opioids in chronic pain management, and then followed by 2016, the fentanyl abuse. Remember, fentanyl is now being produced everywhere in small factories, houses. So fentanyl abuse is not happening because DRAP is not giving us fentanyl. Fentanyl abuse happened in the world because there is too much fentanyl in the world. Completely opposite to the problem that we have in Pakistan. We don't have opioids, remember? And then came the cancer recurrence. So let's take a look at this slide. So there are four aspects to it. So what we know theoretically is that morphine can cause all these problems. That is apoptosis, it kills the cells, then mast cell activation, natural killer cell activation. Again, what we know theoretically is that these actions can cause tumor growth or metastasis. And hence this trend started in anesthesia practice. One of the professors, Irish professor Donald Buggy is a big proponent of this theory that morphine can cause cancer recurrence, something fairly close to our heart working in a cancer center. So morphine can cause, based on this theory, which is, remember, theoretical and in the lab. So why this shift? What actually happened? So as I alluded earlier, there has been certain evidence that cancer recurrence can take place. The first proper work that was published was Perez 2017. The methodology was criticized for various reasons, but the results they produced was in favor that morphine can cause cancer recurrence. But the actual methodology was criticized for not being robust enough. 2021, CDC still says that 213 deaths per day in US are taking place because of opioid abuse. Remember the word opioid abuse, not use. And then enhanced recovery. We don't like that. All the proponents of enhanced recovery don't like opioids. We want to avoid opioids for a number of reasons. One, they can give rise to ileus, then nausea, vomiting is an essential feature which we don't want to have in patients with on ERAS pathway. We want to minimize the side effects. So let's talk about sparing versus eradication. So it's a big spectrum. We want to use opioids, we want to spare them. We want to use opioids, no, we don't want to use, we completely want to eradicate them. So where do we stand in this debate? So we have a big spectrum of our clinical practice. Balanced anesthesia, in which we are using opioids as part of balanced anesthesia. Then we move from balanced anesthesia along with multimodal analgesia. So we want to use balanced anesthesia, employ multimodal analgesia with it, and there is an opportunity for us to spare opioids there. And then the extreme. We don't want to use any opioids at all. So this is a very busy slide. I'm just going to decipher the slide into two parts. The top bit is the opioid sparing anesthesia strategies. So what do we have? So what can we do? We can do a lot of things. We can use ketamine, we can use non-steroidals, paracetamol, regional blocks. We can do quite a lot of things. So we have the opportunity of sparing opioids by employing all these techniques. What are the problems with these techniques? Well, we can, from moving on from this, we can move to the opioid free, which is the lower part of this picture. And we can use magnesium, dexmedetomidine, lignocaine, all these infusions. But then there are challenges. We need monitoring. We have safety issues. We have cost issues. We have expertise issues. So it's not easy to say that we will completely eradicate opioid from our work. So maybe this idea, that we will completely eradicate opioids it pretty much glitters with everyone, but not necessarily something we want to do. So where do we stand? Fact number one, opioids are still efficacious analgesics. We can't get away with it. They are potent analgesics. No amount of wishing will turn paracetamol into morphine. So remember the landmark study 2005 where they compared IV paracetamol with IV morphine, and they said 1 gram of paracetamol equals 10 milligrams of IV morphine. It could not be repeated again and again. There was one study, we all followed it, but then later on, it never got proven again. So no amount of wishing will turn morphine into paracetamol, or paracetamol vice versa. I think the landmark work is this one. This was supposed to be the watershed moment where we were going to completely eradicate morphine from our work. So they made two groups, remifentanil group versus dexmedetomidine group. Remifentanil group was the one that had morphine, and dexmedetomidine group was termed as the opioid-free group. They had to stop the study in the initial stages only because of the problems associated with dexmedetomidine. There was bradycardia and one patient had asystole. So it was not considered safe to carry on with that study. And hence, the whole movement of opioid eradication died in its very initial infancy, I would say. So because of the great and serious adverse events and adverse effects, that study got stopped. Another important work, which is a comprehensive review by Shantana, is a very important one because they were able to answer three very pertinent questions. And I think they pretty much sum up what the whole discussion about opioids. The first question they wanted to ask was, do opioid-free strategies have any benefits above and beyond opioid-sparing strategy? Is the patient going to benefit with this if we give them opioid-free anesthesia? The answer was no. There was no evidence to prove that. So question number one has been answered by this review, that there is no evidence that opioid-free strategies have any benefit for the patient above and beyond opioid-sparing strategies. Question number two, completely sparing possible in the context of existing opioid sparing strategies that we have? Can we do that? Yes, we can do that. It is possible. The first question is, there is no evidence that it has any benefit, but can we do it? Yes, we can do it under certain contexts and for certain procedures, not for every procedure. If you want to do a laparotomy, it would be very difficult to spare all the opioids and go ahead without an opioid. It would be difficult. But yes, if you're doing a knee replacement alone, yes, it is possible to spare all the opioids. We don't have to use an opioid for that. We can do different things for it. And then the question number 3. Do opioid-free strategies prevent persistent opioid use or oversubscription? And I haven't written the word abuse. The answer is no. It's very simple. We are talking about anesthesia and ICU. In anesthesia and ICU, the problem does not exist. This oversubscription and abuse exists in the streets. I'll refer back to my neighbor. He wasn't receiving anesthesia who died because of heroin overdose. So no, this does not go away with that. So what next? Opioid-free anesthesia may be feasible, and it is convenient, it is viable, it is worthwhile, it is desirable, it is optimal. But what we want is remain balanced, etadal. We've always learned from childhood that what we want in our lives is etadal. So we want balanced and rational approach. And that balanced and rational approach dictates that there is no room for eradication of opioids completely from our lives. And this preoccupation with opioid-free anesthesia must not distract us from the real challenge, which is balanced and rational approach, that we as anesthetists have the responsibility. I'll conclude by what Shakespeare said: all the world's a stage, and all the men and women merely players. They have their exits and they have their entrances. And one man in his time plays many parts. And hence, we will continue to use opioids. Thank you very much. Questions abhi honge ke baad mein?
नहीं अभी कर
Okay.
देते हैं. So very
Any questions,
interesting
please?
topic. Any questions from the audience?
I don't. I mean, we can spare them, but I don't want to eradicate them. My position is simple. There is no room for eradication of opioids.
Yes, there's also, I think we must use it limited, and in our part, it's available freely. We should make use of the resource in the next door.
आपकी आवाज नहीं आ रही, मुझे नहीं आ रही.
I think we should make use of the resource available next door and work on the availability of the narcotics rather than trying to eliminate them, and use them appropriately where required. Let's not spare it completely.
So I think this is possible that because we don't have opioids frequently available, we have now started on this bandwagon that we don't need them. And it's very bad for health if we use them. That's not the case.
At one place, you use the term complete opioid sparing, and at others, you have used the terminology of eradication or free. Are they different?
So they are interchangeable, yes. So
Yeah.
completely, we don't want any opioid. You can use the word complete opioid sparing and eradication both.
And have you used this opioid-free anesthesia, like use of lignocaine and ketamine and?
So we have, in our department, we have 2 proponents who are extremely in favor of using opioid-free anesthesia. So it is being, I don't do it, but there are 2 consultants in our department who do that.
Have there been any studies, and how has it been found?
So we haven't, we haven't studied it properly, but I would have the same position that this does not have any benefit for patient outcome or for patient. This does not have patient benefit per se. So this is a classical bias of all of us as clinicians, that we like something, we go after it, we try and find evidence in favor of what we do, and this is where we end up.
Well, actually, I puke madly after getting opioids, and I find that I was looking forward to it, that you will say that's the right thing to do.
I think Dr. S.N. Wakar's message is clear. In the context of anesthesia, it has to be balanced approach. But I would just like to ask the audience, anybody who would go for opioid eradication, please
Yeah, that's
raise
an
your
important
hands.
So anybody in favor of complete eradication of opioids from our lives? I can see one hand, Dr. Akil.
So Dr. Keel, can you just one comment?
My inclination for eradication of opioids started from unavailability of opioid consistently in the anesthetic practice. I'm doing more than my 90% of practice with dexmedetomidine. I do
आपकी आवाज दरमियान में से गायब हो रही है.
Okay. I'm doing thoracotomies, cardiac surgeries, main upper abdominal surgeries, major orthopedic surgery, just with the dexmedetomidine. But I will add that most of the time, I also add BIS monitoring in my anesthetic practice. That adds quite a lot of safety to the patient. But after doing a lot of practice, more than many 1,000 cases, it's possible that we can do an anesthetic without any narcotic. Now the question that comes with the benefit, but unfortunately it's a very short time. We can't do it. The most of the opioid sparing agents are used for not more than 5-10 years. But opioid has a long history, more than 50 years in the medical practice. So time will come when the benefit will be able to compare it. But in the short term, there are definitely some advantages of using opioid-free anesthesia. Thank you.
Thank you. Thanks very much.
Now we move to our next speaker. Our next speaker is Dr. Amir Furqan, and his topic for presentation is knowledge and practice of ultrasound for anesthesiologists. A must now. Dr. Furqan is head of anesthesia and ICU in Chaudhry Parvez Elahi Institute of Cardiology, Multan. He has done his second fellowship in cardiothoracic anesthesia, and added to that, he has also MCPS in health professional education. His special interest is in the ultrasonography implication in anesthesia and ICU, research and medical education. Please.
Thank you, Dr. Amjad sir. Thank you so much. Very dry and heavy loaded presentation we have from morning. Let's have a video. No sound, just concentrate. Thank you so much for your concentration without any sound. I am Dr. Amir Furqan, and recently working as an assistant professor of anesthesia in Chaudhry Pervez Ali Institute of Cardiology. The talk is very simple. Recently, what we have witnessed, these are few challenges that is the present and future of anesthesia. The demand from anesthesiologists is no sleep, no pain, and we have a wonderful surgery event. So this is what future is asking from us. So the topic was awarded by administration of PSA, Karachi. There's a knowledge and practice of ultrasound for anesthesiologists, they must know. While making my presentation, I just searched out the literature. There is a huge number of articles that are observational studies, randomized controlled trials, systematic review, even 6 meta-analyses available, which just provoking this idea that the future of anesthesia belongs to ultrasound. But I just think, why not look at our own practice rather going to the world literature? So I have just a design, a simple survey of on Google form to check what is going on in our own practice and our own society. 5 questions I asked to my responders, and luckily I got 287 responses, but it has some dimensions which need to be looked at. Most of responses I received from the trainees and people working in peripheral hospital, and very few from consultant side. I think consultant have their busy schedules and they merely respond to such surveys. But the observation and analysis of this survey give wonderful idea, the insight about the ultrasound practice in anesthesia field of Pakistan. The first question was whether ultrasound will be the companion of future and will it replace the stethoscope? It was a wonderful observation. Then almost 91% of us believe that the future companion of anesthesiologist is ultrasound, and only 9 disagree with this. This observation clearly giving this message that we believe that ultrasound has importance in anesthesia practice. And we are totally convinced about this. But the next one, are you using ultrasound in your routine practice? This is a simple question. Here, 73% almost saying they have no routine of using ultrasound in their daily practice or in their anesthesia practice. And then next one, do you have ultrasound? And among these, 27% almost saying they have ultrasound, and 18% have in their department, and 9.1% have their personal tools, ultrasound belong to them. And 73% almost, they said they have no ultrasound facility and no access to ultrasound. And next was have they got any sort of training regarding ultrasound use in anesthesia? And again, the same one. Those who replied, yes, they are using ultrasound, almost they are saying they got these trainings, 27.3%. And if they have got the training, from what sort of training they got? The first question was whether there is a routine training in their departments, or they are attending some workshops or getting some certification courses. Only 12.5% saying they have certification courses, and almost 75% are saying they attended different workshops and they get this training from these workshops, and 12.5% saying we have routine training in our departments. maybe they are belong to some big cities. So now why we need ultrasound in our routine practice? I was just working in my routine work. I got a call from a trainee. उसने मुझे कहा सर ये बताएं कि टैब लॉक जो है कितने पॉप्स के बाद जो है वो हम एग्जैक्ट प्लेस पे पहुंच जाते हैं. I just had this question from and then start thinking. मैंने उसे पूछा भी आप क्यों ये पूछ रहे हो कितने पॉप्स के पास पहुंच जाए. Sir, I want to write my synopsis on this. I want to write to compare ultrasound guided tab block with blind technique. So I just reply him कि भाई अल्लाह ने तुम्हें दो आंखें दी हैं तो तुम आंखें बंद करके गाड़ी क्यों चलाना चाहते हो. But this is a angle of thinking in our daily practice कि हम अभी इस तरह से भी सोचते हैं. But on the other hand, ultrasound imaging providing very accurate and non-invasive sort of diagnosis. It's a very handy tool. And we as a physician working in intensive care and a perioperative physician, we can get a rapid diagnosis, rapid and accurate diagnosis, and area of interest can be sorted out with no time. So it's a very reasonable thing to be used. And recently we have such a handy sort of devices that are these wireless devices and then some portable devices which we can easily use in our operation theaters and also in intensive care, and we can carry where we want to take them. So what are the different fields in which we can get the help from ultrasound? We are using in regional anesthesia and then the vascular access. We can pick up the accurate and to plan a better management in emergency cases in, for example, pleural effusion, pneumothorax, pericardial effusion, and the case of tamponade, and then cardiac evaluations, fluid status and airway assessment. And we can use this in neuromonitoring as well and different other monitoring. I also put two questions that not described in previous slide, in which we are mostly using our ultrasound practice in different setups. And among them, more than 80% responded that we are using ultrasound for vascular access. And almost 70 to 80% responded that they are using for regional anesthesia. Very few respond the use of ultrasound in intensive care. That an understandable thing. There may be a deficiency in facilities and the equipments, and we don't have in our setups. So that may be the cause. But few responded that they have routine transesophageal echocardiographies and transthoracic ultrasound as well. But none of them responded that they are using ultrasound for airway assessment. So that may be a new modality for all of us. And neuromonitoring is also there. I received no response regarding the neuromonitoring use of ultrasound. What sort of knowledge we need? Whether it's a very high-tech skill we need to use ultrasound for our routine practice? The answer is no. We just need few basics, concepts, and some basic skills to interpret it and to identify the normality, and then we can just simply identify our abnormality and pathology. Vascular structure identification and the exact area of interest to allocate the vessels and nerves. And when we are talking about the intensive care and pneumothorax, pleural effusion, just to identify, if we are able to identify these normal structure of thorax, that will be enough. And if we are dealing the cardiac patient and we have concept about the valvular structures, the chambers, and then the wall motion abnormalities, that is enough. I have just a study on this question. If we train ourselves and our trainees on these basic skills, that is identification of vessels, nerves, and basic pathology of thorax, and these three domains, how much of the anesthesia practice can be covered? And this study is ongoing. I am collecting data, and hope so in short time we'll share this observation with all of us. And then the specialized domain, that is a cardiac anesthesia, that needs some sort of different studies to be conducted. Now we are going to discuss some basic concepts. We must have knowledge about this, just a revision of that. How structure visualized on ultrasound. Then the hypoechoic and hyperechoic concept. This concept is a very simple one. If structure is creating weak signaling or weak echoes like fluid and fluid containing vessels, they appear as dark structure, black, like vessel, carotid, or internal jugular. They appear as a dark structure. And the other hand,
you have only 2 minutes left. 2 minutes left.
Okay, I'm just closing this. On the other hand, if we have solid structure, more calcification, the echo signals are reflecting in more strength, and these structures always appear in the form of whitish tissue or brighter structures. On the other hand, the same time, nerves can be hypoechoic, can be hyperechoic, depending on their connective tissue contents in their structure and their diameters. These are few basic knobs which an anesthesiologist must know about. That the image optimizing knobs and mode selection more than measurements knobs. Regarding the image optimizing, we must have an idea about the depth selection, the frequency, the gain, and the focal area and color Doppler. If we have idea about these concepts, we can easily implement our knowledge of ultrasound background for the patient care. There's a concept of gain. Gain is the sensitivity of transducer to hair. Higher the gain, brighter is structure. And on the other hand, if the gain is low, the structure is more dark. If we have not optimized the gain, we can misinterpret our findings. Focal area, the area where the rays are condensed and they give best visualization. Most of ultrasound machines have their auto adjustment regarding this focal area, but in some you have manually to focus these areas, that is focal areas. And the color Doppler help us to differentiate between vascular structure, arteries and veins, their pulsatile nature we can easily identify. These are the orientation, whether we want to have short axis views, long axis view, or the oblique views. And these orientation views are used differently in different situations to interpret our concept. And then the appearance of needles, that the inline and out of line. Out of plane, we just have a one dot that is moving on your screen. On the other end, in plane, you can visualize whole the shaft of your needle. So these are the basic concept. This is basically a sensitizing talk about the use of ultrasound and the future of ultrasound. And definitely the future of anesthesia belong with ultrasound. And it's a must knowledge. And we have to prepare ourselves and to design such training infrastructure in our daily routine so that not we can equip ourselves rather than to train our trainees for future. Thank you so much.
Nice presentation by Dr. Amir Furkan. Any questions or comments?
Your survey results were very interesting.
Thank you.
that 70% of trainees did not have access to the equipment, but more than 77 are trained in ultrasound.
No, no. Those who are saying that they have access, among them, they are claiming that they are 27.3%.
Okay, so that is interesting. The need is there. I think equipment is the problem. So
Yes, yes.
hospital administrators, seniors, I think they should provide.
Yes.
And you can do this survey from the platform of PSA across the country as well. Because you have done it in your center only, but I think if we do it across the country level, get these results, it will help the policymakers to decide that we need this. So thank you very much
Thank
for
you.
your talk.
Thank you.
I personally feel, Madiha, that there are two hindrances. One is, of course, the availability of the equipment. Just like the anesthesia machines did not exist once upon a time, I hear everybody used to carry their own anesthesia machine. But then I suppose anesthesiologists put their foot down, no, you have to have a machine and only then I'll come. Similarly, I think we'll have to put our foot down for the ultrasound machine. The second big hindrance I feel is that people who were trained like myself or our generation or even a generation after us, they have not had any exposure to ultrasound. And the only way to make it possible is for us to learn. I mean, I've really gone a long way. कहते हैं ना चीन जाना है तो चीन जाओ तो I went to all over the world too because I wasn't trained in ultrasound. I think ये थोड़ा सा हिच अपनी थोड़ी वो करके और अगर लोग थोड़े से हम लोग अगर इसमें आगे बढ़ेंगे तो it's really a wonderful technique and it's a shame that it's not being utilized as much as it should.
Thank you so much. Regarding the interest of learners, I have just observation about this. I just started a certification course of regional anesthesia in collaboration with the University of Health Sciences. We are just running second batch. In first batch, we have more than 37% people from the peripheral hospital, from THQ and DHQs. And in our second batch, which is started right from January, we have 70% participants from peripheral hospital. Those people have interest to learn. If we can provide them a platform, and from among the first batch participants, more than 50% people has purchased their own devices, their wireless devices, and if they fail to purchase themselves, they get their department agree to purchase them. So the interest of anesthesia community as a community, I think our future generation has a lot of interest in learning. We just have to work on the facilities and to provide them training platforms, and especially non-conventional training platforms on the competency base, which we have debate on first day. We have to concentrate. Thank you so much. Thank you.
One shot. Dr. Amir, we have only a short question for our juniors. So
Assalamu alaikum. I am Dr. Sidra Akram Hassan, FCPS trainee from Trauma Center. So my question is, we use ultrasound to identify a vessel, for example, the IJ, and then we cannulate it. But if we use ultrasound to identify pneumothorax, but we cannot perform tube thoracostomy, then what is the purpose of the diagnosis if we cannot perform it?
Yes.
So there should be simultaneous training for the procedure also along with ultrasound, I think.
Yes, your question has two dimensions. First one is what is the value of detecting pneumothorax when we are not doing this chest intubation? You can just put a needle to deal the dying emergency. So this is a value of detecting the pneumothorax. But the second one is the most important. We must train ourselves and our trainees and our future generation regarding these procedures, these tracheostomies, there's a bronchoscopic guided tracheostomies and mini tracheostomies, and putting the chest intubation, and even to put CVP line to decompress the thorax and other procedures. So definitely it's a very valid question.
okay, thank you, Dr. Furqan.
Thank you.
I think studies
Participants of poster presentation are requested to please line up in front of their posters. The jury members will be visiting them shortly. Please line up in front of their posters. Thank you.
Actually, answering the resident's question regarding use of ultrasound, lung ultrasound especially. So we try to use that because studies are showing it's more sensitive. Small pneumothoraces may be missed on a chest X-ray, and plus chest X-ray needs to be done portable, or many places may not have it. So having an ultrasound machine is far easier than doing the chest X-ray, and it is more sensitive to pick up pneumothoraces. Okay, so it's now my pleasure to introduce our next speaker, Dr. Muhammad Suhaib from Khan University. He's assistant professor there. He's FCPS in anesthesiology and the only FCPS in critical care medicine from anesthesia background in Sindh. So it's really my pleasure to introduce him. Plus, he was also very actively involved in COVID ICU at AKU, and plus he also introduced POCUS. So maybe you can answer the question better about the use of ultrasound in critical care. Welcome, Dr. Suhaib.
Thank you, Dr. Mudiab. Assalamu alaikum, everyone. It's pleasure as invited by PSA Scientific Committee to give a talk on 40th our annual conference, almost after 3 years of physical conference. Slightly jealous from Mujib. I'm not because he was included in young consultant group and I am in old consultant group. So it's on the lighter side. So the topic assigned to me was angioplasties, antiplatelets, anticoagulants, and impact on anesthetic therapeutic decisions. Lot of new oral anticoagulants are in the market. Patients are already on it, and we need to decide whether to continue, discontinue, to discuss with the cardiologist. So quite a lot of literature available on that. So to start with, I have nothing to disclose. The objectives of my presentation will be covering the AHA guidelines, like non-cardiac surgery in patients after angioplasty, classification of anticoagulants, antithrombotics, simply a revision for that, perioperative anticoagulation management, what is the literature now saying that, and regional anesthesia in patients on anticoagulants and antithrombotics. To start with, these are the new guidelines from 2021 from American Heart Association on coronary artery revascularization. I am putting this on my slide. The reason is that it is recommended now in 2021 guideline that there should be no bare metal stents. The coronary revascularization will be with the drug-eluting stents. This is level of evidence A and class of recommendation 1. So now we will be seeing patients with drug-eluting stent mostly, not the bare metal stent. So we have to tailor our therapy according to that. The other recommendation by them was that in patients with non-left main coronary artery or the patients who have a non-complex coronary artery disease, like the patient is not having any arrhythmias going on or a myocardial infarction, so there is no need of simply in perioperative period to do a coronary angiography or angioplasty. So we can proceed with the surgery if the patient have non-left main or non-complex coronary artery disease. This slide is showing some old data, like 2014, we were having the first guideline by the American Heart Association on perioperative cardiovascular evaluation and management of patient undergoing non-cardiac surgery. My topic was what are the timing of angioplasty and after angioplasty, the surgery. So if the patient is having an angioplasty and going for the non-cardiac surgery, so the class 1 recommendation was that the surgery should be delayed for 14 days after simple balloon angioplasty and 30 days after bare metal stent and for 1 year with a drug-eluting stents. Then there was a class 2A recommendation that in patients on whom non-cardiac surgery is required, a consensus decision among treating clinician as to relative risk of surgery and discontinuation or continuation of antiplatelet therapy can be useful. And like they then said that if the patient is having a drug-eluting stent and the surgery need to be performed, and there is a risk of stent, also a risk of stent or thrombosis, that the surgery should be delayed for 6 months, so that patient need to get these antiplatelet therapies till 6 months if the elective surgery is planned. And they said that class 3 recommendation was the harm, that elective non-cardiac surgery should not be performed within 30 days with bare metal stent and within 12 months after drug-eluting stent. And elective non-cardiac surgery should not be performed within 14 days of balloon angioplasty in whom we think that we need to discontinue the aspirin therapy. Like if the patient is on a high dose of aspirin therapy, like more than 200 milligram per day. This is the graph, the same thing which we have discussed. The things mentioned in green were the class 1 recommendation, and in yellow is class 2A recommendation. Then there was a huge debate about that elective surgery need to be postponed for 1 year with the drug-eluting stents, and if the surgery is deemed necessary, we need to continue antiplatelet therapy till the 6 months, and then we can perform the surgery. So there was a focus update in 2016 by American Heart Association on that. They simply said that the class 1 recommendation was that the elective non-cardiac surgery should be delayed 30 days after bare metal stent implantation and optimally to 6 months after drug-eluting stent implantation. So this was the change that in 2014, they were saying that we should wait for 1 year, then they shift to the 6 month duration of the time. And the other thing they said that elective non-cardiac surgery after drug-eluting stent implantation in patient for whom that P2Y12, like clopidogrel, the patient is if it's on clopidogrel inhibitor therapy, will need to be discontinued, may be considered till the 3 months. So in 2014, they were saying that 6 months is the optimal period for dual antiplatelet therapy. In 2016, they changed that they said that the therapy can be discontinued if the surgery is deemed necessary. Then we can stop these antiplatelet drugs at the 3 months. Then in 2017, a European Society of Cardiology said that if the patient have a stenting and the patient need to go for the surgery, the minimal duration of dual antiplatelet therapy should be 4 to 6 weeks. We cannot discontinue dual antiplatelet therapy before that. If it's an emergency surgery, we are not talking about the emergency surgery because at that time we have to weigh the risk versus benefit. This is for the elective surgery. Then there was again a Canadian Society guidelines, Cardiovascular Society guidelines. They also gave a focus update on the dual antiplatelet therapy for how long we should continue. So they said that the inpatients undergoing PCIA who are treated with either a bare metal stent or drug-eluting stent and who require elective non-cardiac surgery continue aspirin perioperatively whenever possible. And in patients undergoing PCIO who are treated with bare metal stent or drug-eluting stent and they are on some antiplatelet therapy like clopidogrel or ticagrelor for 5 to 7 days held to be preoperatively and 7 to 10 days the prasugrel. In patient undergoing PCIO treated with a bare metal or drug-eluting stent and who have undergone non-cardiac surgery, restart maintenance dose dual antiplatelet therapy as soon as it is deemed safe by the surgeon. The surgeon says that now we can start intraoperatively there was no bleeding, so we can start, but it should be started within 24 hours. I will mention in my slides. Now, people have tried that if the patient is on a dual antiplatelet, they try to stop that and they try to bridge that with some other anticoagulation because the main problem with the stopping of these dual antiplatelet is stent thrombosis. Stent thrombosis will lead to reinfarction. So people have tried bridging with this platelet PY12 receptor blockers IV like glycoprotein 2BA, 3ABA inhibitors, but this is not favored because there the risk of bleeding was much higher with these IV glycoprotein 2BA, 3A inhibitors. And one of the questions someone asked that if the patient suffered from MI and we start, should we start heparin perioperatively? We start anticoagulants. So we can, there is no literature or evidence on that because if the patient is on dual antiplatelet, we start heparin. This will not help in decreasing the risk of stent thrombosis. So we need to continue these dual antiplatelet therapies. Why we are discussing that why we should postpone the surgery. So this slide clearly shows the burden of disease. Despite recommendations to delay the surgery, surgeon always plan the surgery. And this is hard. This is the fact. So 3.5% of the patients or more undergo non-cardiac surgery within 6 months of stent placement. This is a study published in 2019. And one of the study published in 2020 shows that 4 to 11% undergo PCIA, having a PCIA underwent non-cardiac surgeries. This is one of the study that perioperative cardiovascular risk of prior coronary stent implantation among patients undergoing non-cardiac surgery. This was published in 2015-16, and the conclusion that if the surgery is performed in within 1 year time of coronary stenting, there are this is one of the independent risk factor of adverse major cardiac event. This is the forest plot clearly showing the major adverse cardiac event, death, myocardial infarction, cardiac arrest. These all showing that if the surgery is performed within 1 year after the PCIA, then the chance of complication is quite high. This is one of the study which is published in American Heart Journal, which shows that despite clear guidelines to avoid surgery early after PCIA, non-cardiac surgery was performed in 1 of every 29 patients. The patient who have got PCIA, 1 in every 29 patients undergoing surgery. And this is the graph clearly showing that if the surgery is performed less than 1 month, like in a black bar graph showing the chance of death or myocardial infarction is quite high. So the surgery should be within 3 months to 6 months period, which they have advised in 2016 update. Then I started doing the literature search. I think so this is a good idea to get one of us can do an article on that or a review the data, because I tried to search that when the patient underwent PCIA and they are planned for surgery, and if the surgery can be done in regional block or neuroaxial anesthesia and compared to the general anesthesia, what are the outcomes? So it was in 2014, this is the last article which I found in Cochrane. After that, there is no data that if the patient is under, data might be there, but I was unable to find that. If the patient underwent PCIA and or any stenting or balloon angioplasty, and they have undergone the surgery, neuroaxial versus general anesthesia, so the data was not available. This study only shows that they included every patient having moderate or high risk for major adverse cardiac event, but they do not mention that how much patients have stenting done or how much have a balloon angioplasty done. But this data shows that clearly the neuroaxial anesthesia is actually favorable in decreasing the major morbidity and mortality, 30-day morbidity and mortality. Now the next slide showing only the revision that the classification of anticoagulants, we have oral, parenteral. In parenteral, we have direct, indirect, and in oral as well, direct, indirect. And we are mostly doing unfractioned heparin, low molecular weight heparin. In factor 10A, oral direct inhibitors are rivaroxaban, like we have very much hearing of that in COVID as well, people on rivaroxaban. Then there is the classification of antiplatelet drugs like COX inhibitor, P2Y12 inhibitors, glycoprotein 2B, 3A inhibitors, and phosphodiesterase inhibitors. I just want to mention that phosphodiesterase inhibitor, the mentioned drug is celestazole. Our vascular surgeons are very much prescribing this drug to every patient for having peripheral vascular disease. And incidentally, one day they planned a surgery of femoropopliteal bypass graft, and they told me that the patient is on celestazole. I started searching on that, what is that? And then I found that this is phosphodiesterase inhibitor. This is a calcium channel blocker, and it should be withheld for any surgery 72 hours before surgery. And when I told the vascular surgeon, he was arguing with me that you are the first anesthesia consultant who is saying that. and we have done a surgery 2 days back and the anesthetist performed the central neuroaxial block. And they said that let's do a study on that the patient who was receiving celestazole in the past 5 years, do they have any complication with this regional anesthesia? I told them that there are clear recommendations from different societies that celestazole should be held. Why we are doing this study? That actually we are arguing with their recommendation as well. So we have a plan on that. We will see that how much patients have gone complication. We can report with that. Now, perioperative anticoagulation management. We have to first evaluate that patient is on anticoagulation or antithrombotic drugs. So first, to determine the thromboembolic risk of the patient. Is the patient really at risk of perioperative thromboembolism? the broad classification of the 3 patients which can be on high risk of venous thromboembolism is the patient is having atrial fibrillation, patient having prostatic heart valve, or patient have a recent thromboembolism. So these are the patients which are at high risk of any thromboembolic risk. So stopping the thrombotic drug will be a risk. So these patients might need a bridging therapy. The other is determine the procedural bleeding risk. How much we are anticipating that this procedure will cause the bleeding. So if the procedure is high risk for bleeding, so we can stop this thrombotic drugs. And determine whether or not interrupt anticoagulation or antithrombotic therapy will give the answer of the first 2 questions. Either there is a bleeding risk, so we should stop that, or either there is a risk of thromboembolic phenomena, we need to continue that. This is the perioperative guidelines on antiplatelet anticoagulation agents 2022 update. This is published in current anesthesiology reports. It's a review article actually. I started to look for a literature that what is high risk procedure for bleeding, what is low risk for procedure bleeding. There are different classifications, but I like one of the lines by someone that if surgeon says there is a risk of bleeding, this is high risk procedure. So if surgeon says there is a bleeding, and we are anticipating, no, this is written in a guideline that is a low risk procedure, avoid that. Listen to the surgeon. If says high risk, that it's high risk. This is the graph. This is a table showing the minor surgery, major surgery. These are the same. For rivaroxaban, it's like if the minor surgery go less than 24 hours, stoppage is required. And if it's a major surgery, 48 hours are required. And we can start after again 24 to 48 after the surgery. Aspirin with the same, we can usually continue with minor major surgeries, no issue with that. Clopidogrel, the same 7 to 10 days. And these are that. The hysteric marks on the rivaroxaban are showing if we need to see the creatinine clearance of the patient. If it's less than 30, we need to measure the levels before proceeding for the surgery. This is the slide which shows that either we need to bridge the patient with bridging therapy. There are a lot of data about conflicting data about this bridging therapy. People on vitamin K antagonists like warfarin, they do bridging with heparin, deltaprin, but there are 2 big trials, bridge trial and periop trial, which clearly shows that by bridging therapy, there are increased chance of bleeding and there is less chance of any thromboembolic event. But in the previous slide, as I said, that if we identify that this patient is high risk for any thromboembolic phenomena perioperatively, like patient has a AFib, prostatic heart valve, or any recent embolism, so we need to bridge that. And bridging can be done with heparin or deltaprin, either with that. Now we go to my last couple of slides on the regional anesthesia and anticoagulation. There are the recent guidelines published in European Journal of Anesthesia on regional anesthesia on antithrombotic drugs, published lately in January. These are the same. Interestingly, they have divided the blocks into 2 categories. One is superficial block and the other are D blocks. Superficial means if we accidentally we have a bleeding complication, it is ready can be managed. It can there is a less chance of any hematoma formation or anything like that. D block. And interestingly, they have divided head and neck block. That all chronic pain blocks are actually the D blocks, along with that spinal or epidural. Interestingly, all brachial plexus blocks are superficial block except the infraclavicular block. That is considered, that is labeled as a D block. So they have made the classification because they want to see that for which blocks, how much anticoagulation should be stopped before performing the block. So this is the management of high bleeding risk blocks.
So
like,
you have 1 minute.
okay, ma'am. But these are 2 slides. Right? Neuraxial block and a deep nerve block. So that was actually they have given more than 40 recommendations. So I cannot put all that into this presentation. But like low molecular weight heparin, high dose, low dose, like same that 12 hours, 24 hours to perform the block. There is no need of testing. But if the creatinine clearance is low, then we need to see the factor 10A levels. Like fondaparinux, high dose, we have to stop before 36 hours. Unfractionated heparin, like that 4 hours, 12 hours. The same which have been previously in the guidelines. Same for their clopidogrel, that is 5 to 7 days of clopidogrel, you need to stop that, the most common drug we use. The interesting part is management of bleeding in superficial nerve blocks. So if the patients are taking all these drugs, like in a prophylactic dose, we do not need any time interval to perform the block. We can perform block on the same day. And we can also perform the block if the patients are taking therapeutic doses of these anticoagulants like vitamin K, low molecular weight, unfractionated heparin, aspirin high dose, or clopidogrel as well. The time from the last drug intake to intervention is 0 if within or below the patient's individual therapeutic range. The last slide, how to perform emergency reversal of anticoagulation. There is reversal of warfarin we can do with like prothrombin complex concentrate. We can perform FFPs. We can give transamine as well. But remember that prothrombin complex concentrate takes 6 to 24 hours to complete reversal. For if you transfuse FFPs, after transfusion, it takes 15 minutes to completely reverse. But to gain the complete remission, that INR will be normal, that almost can take 36 hours. And reversal of anticoagulants like heparin, we have protamine as well. But interestingly, reversal of direct anticoagulants, like oral anticoagulants, like rivaroxaban, if we have to perform an emergency surgery. So this is a new drug, FDA approved, andexanet alpha. But fortunately, the cost is so high that it is not used routinely. In one of the articles, it was written that $50,000 is the cost in comparison to prothrombin complex concentrate, that is $5,000. So it's an expensive drug. That's why it's not very much in the market. Thank you very much for listening to me.
Thank you, Dr. Sohaib, for updating us on this very important topic, because every anesthetist will be confronted by a patient who has had PCI. Any questions from the audience? Sabko sab samajh aa gaya. So my only question is, in the Cochrane systematic review that you mentioned, that they have shown neuroaxial better outcomes with neuro. Did they look into complications of
Yes,
neuroaxial block?
No, they mentioned that the only factor which favorable the most good outcome was the absence of pneumonia in patient underwent for neuroaxial anesthesia.
But the neuroaxial anesthesia itself, isn't it a bold decision when the patient is on dual antiplatelets to do a spinal?
Definitely, because they actually included whole population that underwent that had either underwent PCI or they are only taking the drugs. We don't know, because actually I was looking for the data that the patient particularly who underwent PCIA or CABG, what is the difference between these two populations? Like the patient who underwent PCI or CABG or other patients which are only taking the drugs. So what and type of, but no data. I was unable to find
So
that data.
you yourself will give spinal or epidural
Yes,
if the patient is on dual antiplatelets?
There is a line written in now European Society of Regional Anesthesia guideline. If in obstetric patients you think that GA is not good for that patient, if I decide, then I can deviate from these guidelines that we have to wait for 5 to 7 days, explain the risk to the patient, and then you can perform this neuroaxial block. I have the example of silestazole. We are doing from the last 3-4 years. Just on a one day, one of the surgeon came and said that I looked for that it needs 72 hours stoppage before performing any neuroaxial or GA anesthesia. So like that, I think so that the complication rate might be less with that neuroaxial block if the patient is already on antithrombotic or anticoagulant. But if the time duration we have elapsed, so might be.
So we'll wait for your results of your study you present next year. Thank you very much.
Now, I would like to invite our last speaker of the third session, Professor Zayed Akhtar Rao, and his topic for talk is medication safety, look alike, sound alike, medications need to be banned. Professor Rao is currently working as chairperson anesthesiology and critical care and director postgraduate medical education at Fazaiya Ruth Fau Medical College, PAF Faisal, and his special interests are critical care and airway management. But I have seen him a lot of times that he has a lot of patience for teaching, and I'm also inspired from his teaching patient. Thank you.
Thank you. Thank you very much. First of all, I thanks the scientific committee to allotting me this topic. It is a very difficult topic. Medication safety, look like, sound like medication need to be banned? This is the question. So I started Google. So what is the evidence in worldwide and what is the evidence in Pakistan here? So what I have found, I'll try to share you. The objective is at the end, I hope you will be able to know the burden of the problem worldwide and what is the situation in Pakistan and what is the importance in prevention of these errors. Does Lassa medication need to be banned really? Then explore the solutions and summary at the end. So despite of recent development in different safety measures, that is making inventory management, introduction of the electronic drug trolleys, color coding of the syringes of different drugs, and maybe more inventions, but medication error could not be eliminated yet. The existence of the confusing drug name that look like, sound like, or read like, it is concerned not only in Pakistan but worldwide. The presence of tens of thousands of drugs currently in the market are potential of error due to confusing drug names and look like or sound like. These are the few examples of drugs which are present in our setup. Just they are looking like the same, and there are many medical errors are going to be happening. It is the other thing that we are not reporting these errors. So we look the literature what it says. So what are the contributory factors for this confusion are, first of all, the eligible writing, how we are writing. If doctor writes the medicine, I think it is very hardly to read for him also what he has written. There are so many prescriptions I have seen that they are unable to read. Then incomplete knowledge of drugs, names, there are different names. They are very similar and doctor don't know what are the different like this name or other present. So they sometimes they spell wrongly, and the different drugs you can get from this pharmacy. Similar packaging and labeling. This is the very concern of today's. Similar clinical use, similar strength. The similar type of the drugs with different strengths are available. And sometimes if you want to give 20 milligram, you may find the 40 milligram ampule also, and it can be mistaken from the. But for me, the most important is the failure of manufacturers and regulatory authorities to recognize the potential for error and to conduct rigorous risk assessment. When I searched, I found the recent WHO September 19 that they said the medical mistakes causes 2.6 million deaths yearly. And more than 138 million patients are harmed every year by doctors. It's a huge number. In America, the estimated 64 million errors occur during the dispensing of 4 billion prescriptions annually. And many Lassa errors occur in hospitals. The potential is at least as great in outpatient care setting also. Approximately 25% of Lassa medication errors reported to national medical error reporting programs. That is, it is published in 2000, April 2000. In UK, between 3 months, January and March 2018, they counted for 10.7% of incidents. That is 206,485 medication incidents out of total 19,36,000 and 63 deaths. Another publication in 2009, Lassa errors make a high proportion of all medication errors. Estimated ranges from, in different studies, 6.23 to 14.7%. In Pakistan, what is the situation? One of the article I found, that is a multi-center cross-sectional survey, medication-related knowledge among Pakistani nurses. This study sample was comprised of 2,363 registered nurses. Around 84% of study participants having poor knowledge of high alarming medicines, high alert medicines administration as well as regulation. What were the causes? They found that the answer was the getting uncertain answers from the colleagues. 72%, 73% of the nurses replied that they are getting uncertain answers from their colleagues. Unavailability of suitable person to consult, 61% replied. And receiving verbal orders, that was the 55.6%. Another study of the resident medical doctors in Karachi, the total number of 130 residents were included in this study. Majority, that is 98%, 128 of these described some form of error they noticed during their training. But only 73% residents disclosed medical error to their senior physicians. But disclosure to patient's family was only 15%. What was the reason of this medical errors? They found it. Fatigue due to long duty hours, 85%, 85 resident, that is 65%. Inadequate experience, that's the 52%, and inadequate supervision, that is 48%, and complex cases, that is 45%, was the cause of the error, as they think. In another study, I must congratulate who has published this study. Otherwise, once we found some error, we put it under the carpet and don't disclose and don't tell anybody. So they published the single hospital study, 515 inpatients prescriptions, 427 medication error were reported. You see how 515 inpatients, 427 medical errors. Another study from Karachi, 200 prescriptions were shortlisted overall, and the total they found 38 Lassa errors were reported in 90 days. It is only 93 months study, and that is 19%. So in near past December 21, the National Health Service Regulation and Coordination Pakistan, with the support of WHO, has launched a study on medical error at public health facilities in Pakistan. This study will provide data and guidelines to prepare national patient safety and quality policies and strategy to prevent medical errors. This is the recently WHO has given this. In Pakistan, DRAP, Drug Regulatory Authority of Pakistan, identified 104 alike, look-like and sound-like medications among the 70,000 registered in country, and they are prone to cause confusion. They have directed their manufacturers to rename them and change their packaging. So, who should be blamed for this LASA errors? And what measures we can do at different levels? To me, the regulatory authority is the most important authority which can regulate these type of the drugs, and they can order, they can regulate the manufacturers that they should not keep the names alike. So other preventions are at different levels, at manufacturer levels. They are mainly responsible for health product. They should choose unique drug names, easily written and pronounced. They can use tall lettering, that is, some words are very prominent, just like dobutamine and dopamine. Barcoding, and while proposing a drug name, brand and generic, they should do complete research to ensure that there are no drugs with similar name in the market. They can do the computer research. At the physician level, yes, in order to avoid LASA confusion, the prescriber can clearly write prescriptions, avoid using short terms and abbreviations of drug names, make further comment about their drugs, including both generic and brand names, and most important, avoid verbal prescriptions to the maximum extent. We are habit of telling on phone, ये इसको ये दे दो, इसको ये लिख दो, इतना कर दो. अच्छा, उसमें ना कोई आप डोज उसको प्रिस्क्राइब करते हैं, वो सिस्टर की मर्जी है, रेफरेंस की मर्जी है कि उसने जब समझा और जो कहा वो दे दिया. At pharmacist should ensure that the patient receives the correct drug as prescribed by the physician. They do so by separating LASA drugs from one another, installing warning system to staff, computer alerts, or warning on stock bottles,
Only 2 minutes are left.
double checking the drugs, contacting the physician in case of any clarification regarding the prescription, and becoming familiar with LASA drugs. At consumer levels, consumer must be aware as to why that particular drug is prescribed and the appropriate usage of that medicine. They should confirm that the physician has already clearly written the name of the drug, and patient must be able to read that name of the drug. After buying, they should ensure to see whether the drug is in hand is the same as one that is in prescription. So I couldn't find any recommendation to ban these drugs. So in summary, we can prevent by observing these precautions at different levels. So till now, there is no option to ban LASA drugs worldwide. Reducing interruption and destruction while prescribing, while dispensing the drug. Storage strategies, typographic intervention, Talman lettering, barcoding, and computerized physician order entry. Thank you very much.
Thank you. Very elaborative about the magnitude of this problem. And I know there are underreporting, especially in our setup. And there are many more factors are involved rather than it's prescribed. And one, the most important factor is especially in our ORs, what happened because of severe shortage of anesthetists. most of the time the drugs are dispensing by the technicians or nurses. And at that time, because of the communication blunders, most of the errors happen.
Yes, you are right. That is why this reporting is, I think I find only this few, I salute them that they have reported these cases. And every times in every hospital you find, has been done with me also many times. When I received drug from the pharmacy, they were the different drugs. So it is always there and everywhere.
Any questions or comments? Dr. Fozia is on the safety of the.
Thank you very much. Thank you.
No, it's heartening to see that DRAP is doing something, and we have at least data from our own hospitals. So hats off to people who are reporting, and DRAP is doing something about it. So eventually it will be done.
Yes.
So thank you very much for
Thank you.
highlighting all these things. I think with that we come to the end of the session. We thank all the speakers
Yes, madam.
and present them with certificates.
Ji, madam. Dr. S. N. Vakar, sir, can you please come on stage? Madam, again. Dr. Amir Furqan. Dr. Mohammad Sohaib. Professor Zahid Akhtar Rao, sir. Now, I would like to request Professor Dr. Gaurav Shant to please come on stage, please. This concludes our session 3. Now we will start with the session 4, which is the resident free contest paper. The chair for this session is Professor Salman Waris. Sir is Professor Emeritus at Nishtar Medical University, Multan. He's also a member of the Faculty of Anesthesiology, CPSP. Plus, to his credit, he has over 200 FCPS residents and more than 200 DA and MCPS students have passed under his supervision. Sir, can you please come on stage? A big round of applause for him, sir. Now, I would like to request Dr. Professor Naveed Masood, sir, to please come on stage. He's a senior consultant at the Indus Hospital in Karachi. The free paper residents are requested to please line ahead. You will be called in your order, please.
Assalamu alaikum. We have about 9 free papers and 33 posters. And first of all, I would like to announce the name of the jury for free paper. Number one is Professor Rana Altaf Ahmed. He is Vice Chancellor of National Medical University, and he has experience of intensive care, cardiac anesthesia, and pain medicine for over 35 years. Has over 28 national and international publications, and is member faculty of Anesthesiology, CPSP. The next jury is Dr. Hamid Akil Naqvi. He is Associate Professor, Department of Anesthesiology, the Khan University Hospital, and he has got a special interest in cardiothoracic anesthesia, mechanical support of failing heart, and clinical anesthesia. And the last jury for this free paper session is Professor Ismat Wasim Chaudhary. He is head of the Department of Anesthesia at Akhtar Saeed Hospital Medical and Dental College, Lahore. He served for 20 years as professor and head of the department, Postgraduate Institute, Lahore. I would request all the jury please to come on the stage of free paper. Or you, if you are comfortable sitting over there, as you wish. Are you happy over there? Okay, you are now. Okay.
The jury for the poster session is Dr. Mohsen Nazir, Assistant Professor and Consultant Anesthesiologist at Khan University Hospital, and Special Interest in Perioperative Medicine, Airway Management, and Clinical Research. And the second one is the Professor Safia Zafar Siddiqui. He is head of Department of Anesthesia and Surgical ICU and Pain Management, Civil Hospital, Karachi, Dow University. And Professor Sadka Aftab, she's head of Department of Anesthesia, Shaheed Mohtarma Benazir Bhutto, Trauma Center, Karachi. He remained head of cardiothoracic anesthesia at Civil Hospital for more than 20 years. Now she's leading the trauma center. The poster section is in marquee, and this jury is already judging them in the marquee. The first speaker now.
There are 9 speakers, and let me remind all the speakers that you have just 8 minutes per presentation. And I don't think we'll be having a lot of time to take a lot of questions, okay? The first paper is pre-medication with gabapentin for laryngoscopy, a double-blind randomized controlled trial in hypertensive patients. Dr. Hajra Zafar from CHK, Civil Hospital, Karachi.
Assalamu alaikum, everyone. My name is Dr. Hajra Zafar Siddiqui. I'm an Year 4 resident at Department of Anesthesiology, Civil Hospital, Karachi. The title of our study was Pre-Medication with Gabapentin for Laryngoscopy, a double-blind randomized controlled trial. Introduction. Laryngoscopy for tracheal intubation is a potent stimulant for sympathetic outflow, which can be dangerous in certain patient types. Multiple techniques have been used over the years to prevent these pressor responses. Gabapentin is a structural analog of gamma-aminobutyric acid and has been used as an anti-epileptic and for managing pain. Our rationale in this study was to see the effect of gabapentin in controlled hypertensives who were undergoing elective daycare procedures and had missed their morning antihypertensive dose. The objective of our study was to compare the effectiveness of gabapentin on the mean arterial pressure in response to laryngoscopy and intubation in hypertensive patients undergoing daycare surgeries. So talking about the methodology a bit, our study design was a double-blinded randomized control trial. 150 known hypertensives were taken into this study. Informed consent was obtained from them, and approval from the ethical review board of our hospital was obtained. The participants were then divided into 2 groups, the gabapentin group G and the placebo group P. Discussing the inclusion criteria, we had patients in between range of ages 35 and 65 years old. Patients were controlled hypertensive with no other comorbidities,
and those who had missed their morning dose of antihypertensive. We excluded all patients from our study who had anticipated difficult intubation or were at high risk of aspiration, for example, patients with hiatal hernias. Patients with a BMI of greater than 30 were also excluded from this study, as were patients with ischemic heart diseases, cerebral vascular accidents, and patients with known arrhythmias. And patients who had taken their morning antihypertensive doses were excluded. So talking about the methodology a bit, capsules of gabapentin and the placebo are assigned specific serial numbers in this pharmacy of our hospital. And from there on, they were dispensed to the pre-op assessment region 2 hours prior to the surgery, where they were given to the patient with a single sip of water. The capsule with the gabapentin contained 800 milligrams of the drug. Thereby, patients were taken to the OR, where standard monitoring was applied and anesthesia was induced thereby, using propofol 1 milligram per kg, nalbuphine 0.1 milligram per kg, and atracurium 0.5 milligram per kg. Anesthesia was thereon maintained with 40% oxygen and 1.2% of isoflurane by volume. Heart rate, blood pressure, and ECG were recorded before induction, after induction, immediately after intubation, which was time 0, at 1 minute, 3 minutes, 5 minutes, and 10 minutes after intubation. Effective readings were all those which remained within 30% of the baseline. So our results were analyzed on the statistical package for social sciences version 20. Groups were compared in terms of on the basis of the chi-square testing. And as you can see over here, effectiveness for the drug was considered when MAP remained within 30% from baseline and had a significant p-value. More results to follow. We also saw when results were compared, ages of lesser than 40 and between ranges of 41 to 50 were found to be significant for the p-value. Female gender showed more significance with a p-value of 0.005. The BMI of lesser than and equal to 25 or 25 to 29.9 were also found to be significant. And patients who were undergoing treatment for hypertension for greater than 10 years showed significance. These drugs can also be seen graphically represented, where placebo and gabapentin is compared in terms of heart rate, and then again in terms of mean arterial pressure. So if we are to discuss, laryngoscopy and tracheal intubation results in marked stressor responses, which manifest as changes in heart rate, arrhythmias, and blood pressure rise. And obviously, they can be life-threatening for certain patient types. So Serret et al. Compared 400 milligrams and 800 milligrams of gabapentin and reported that the lower dose of gabapentin was found to be ineffective. Another study by Bala et al. Used 800 milligrams of gabapentin on controlled hypertensives, showing similar results as our study, but we included only those patients in our study who had missed their morning dose of antihypertensives. The strength of our study was the double blinding and the randomization on the specific subgroups of hypertensive patients. Compared to another strength of the study was that when compared to fentanyl, lidocaine, and clonidine, gabapentin showed inferior results for many hemodynamic parameters. But in our country, all of us are aware of the fact that fentanyl and clonidine, both the cost and the availability is a serious concern. So gabapentin is more widely available and is economical. The limitation of our study was that patients were on multiple antihypertensive, including the beta blockers, that could have affected hemodynamics. Other limitations, including overlooking post-operative sedation, post-operative pain scores, and post-op hypotension. The absence of BIS monitoring, which is the lack of depth of anesthesia monitoring, could have led to awareness of pain and thereby could have led to the change in hemodynamic parameters. So we were able to conclude that 800 milligrams of gabapentin is effective in attenuating the cardiovascular pressure responses to laryngoscopy and tracheal intubation in hypertensive patients. These are my references. Thank you so very much.
We can just take one comment or one question. I would just like to ask that gabapentin causes a lot of sedation.
Yes,
So
sir.
were the patients over-sedated after that?
Sir, that was a limitation of a study which could be improved in studies that are to follow, because we were not able to monitor that part of the study.
Okay, thank you very much.
Thank you. Thank you so much.
Now the next speaker is Dr. Aisha Tahir from Lahore, Liaquat National Hospital. The topic is to evaluate the prevalence of burnout syndrome among anesthesiologists residents in the tertiary care hospitals in Karachi.
Assalamu alaikum. I am Dr. Aisha Tahir. On behalf of Liaquat National Hospital, I welcome you all in the 40th PSA conference. Few years back, when I joined my residency, I was very much surprised and obviously disturbed too, because of the attitude of every other person. That forced me to think that what is the problem? Either I am bad or something, or what? Then after a year, I observed a change in my behavior too. And my family pointed it out, my friends pointed it out, and that change in my behavior and that change landed me here in front of you, presenting my paper on the prevalence of burnout syndrome among anesthesiologists of Karachi. The rationale of my study was conducted with the purpose to know the prevalence of burnout. It may be used by health professionals to institute meaningful interventions to control the problem. The results created awareness among health personnel regarding the problem. It was a cross-sectional study in which I took 144 residents equally from the government and the private sector. The study was based on MAS/burnout inventory questionnaire that comprises of 22 questions. And the burnout, as we all know, burnout comprised of 3 dimensions, that is emotional exhaustion, depersonalization, and feelings of reduced accomplishment. So all the 3 components were evaluated in this questionnaire. Each question is scored using a 7-level scale ranging from 0 to 6, from never to every day, allowing for sub-scale assessment in all 3 dimensions. It was the random sampling was done by taking the prevalence of 10.4%. The margin of error was 5%, and the confidence level was 95%. Data was analyzed by using SPSS version 25. Mean and standard deviation were computed for quantitative variables. Frequency and percentages were calculated for qualitative variables. So according to my study, the result was the mean age of residents in private hospitals were 32.9 plus minus 12 years, and in government setup 30 plus minus 4 years. There were 58.3% males and 41.7% females in private hospital, while 51.4% and 48.6% females in government hospital. The mean working duration was found as 90 plus minus 25 hours in private hospital and 64 plus minus 12 hours per week in government hospital. This makes the huge difference. Like in private hospital, we have huge working of hours as compared to government hospital. The mean score of emotional exhaustion and depersonalization and reduced personal achievement was calculated. The burnout was found as 18.1% in private hospital and 12.5% in government hospital. That mostly correlates with the increased working hours in private hospital as compared to government hospital. So the burnout was In private hospital, it was 18.6%, and in government hospital, it was 12.5%. So the first time the term burnout was coined by Freudenberger in 1974. Then in 1986, Maslach and Leiter concluded with the definition that burnout is a chronic stress disorder that results in emotional exhaustion, depersonalization, and reduced personal achievement. If any of the person has two components, so they are at high risk of burnout. But if the person has all the three components, it means that the person is already burned out. So the why it is important to know about burnout? Because if the person is burned out, it clinically manifests as the physical, emotional, behavioral, and psychological problems that varies from fatigue, headache, rise in blood pressure, disturb in sleeping pattern, and to even the complete social withdrawal. Anesthesiologists try to compensate stress with social withdrawal, cynicism, and persistent tiredness, but this compensation quickly reveals to exhaustion, and in this ways begin emerging depression or anxiety symptoms, chronic pain syndrome, or functional disorders of the cardiovascular or GI symptoms. So the burnout assessment in my study was done by these scores. The emotional exhaustion was scored as for moderate burnout, it was 18 to 29. Below it was low burnout, and above this score was high burnout. In personal accomplishment, the moderate burnout was ranging from 34 to 39. Above it was low burnout, and below it was high burnout. And depersonalization, 6 to 11 score was mentioned as moderate, less than 5 was low, and more than 12 was considered as high burnout. So the consequences of burnout is a lot of studies demonstrate burnout increases the incidence of medical error. In fact, long time periods of continuous wakefulness result in deleterious effects, impaired concentration, vigilance, short-term memory. In 2011, Vela and his colleagues did the study in which he says 24 hours without sleep undermines the ability to perform certain cognitive tasks to the same degree as the ones from a blood alcohol level of 100 milligram per deciliter. Some studies have shown an increased risk of suicide among anesthesiologists compared with other physicians and compared with general physician risk. In fact, doctors in general and anesthesiologists in particular have a reputation for heavy drinking. So my study was compared with another study that was a systemic review. And in this review, it shows that burnout prevalence greatly varied across studies, 10% to 41% for the high risk, and for the moderate risk, 59% of the anesthetists were at the moderate risk. Another study by Stella was done in Romania, and it suggests that burnout syndrome among medical staff with Maslach burnout inventory had a total score of 68. Another study was done among the anesthesiologists of American Society of Anesthesiologists by Afonso in 2019. This study says that 13.8% of the anesthesiologists met the criteria of burnout, whereas 59.2% were at high risk. Another study was done among anesthesiologists in the Federal District in 2021 that shows the 10.4% prevalence of burnout syndrome among anesthesiologists. So the outcome was that given the severity of burnout consequences, the health of anesthesiologists require more attention. From the organizational standpoint, the work in the OR generates an overload of work and occupational stress. A periodic monitoring of these professionals' mental and physical health is recommended to organize their work process and reduce for stress resources. For managing the burnout, it is important to recognize the stress behavior and identify what causes it. After that, the goal is to eliminate the individual, environmental, and collective stressors. Another measure that is mentioned to manage burnout is the use of music at workplace. Communication is also considered as measuring coping, although controversial. So I concluded with this, that we observe variation in burnout in private hospital versus government hospital. Residents working in private hospital work for extensive hours as compared to government hospital. There is an extensive need of comprehensive support groups, human number of working hours, improved de-stressing activities for mental health of resident physicians, and enhance their productivity. And the limitation of my study was that it was a cross-sectional study. So that I only examined the exposure disease relationship in a given population or sample at a particular moment. Furthermore, the use of a self-administered questionnaire can generate differences in interpretation of the questions. So these were the references. Thank you.
Thank you, Dr. Aisha. Very nice presentation. Actually, we are running short of time. We can't take a lot of questions. Thank you. Our third presenter is Mr. M. Amar Amjad from Shaukat Khanum Memorial Cancer Hospital. And the topic is prevalence of chronic pain in Pakistan, a national survey.
Thank you so much. So I'm Dr. Amar Amjad. I'm currently working as a resident in the Department of Anesthesia at Shaukat Khanum Memorial Cancer Hospital and Research Center. So we'll be talking about prevalence of chronic pain in Pakistan, a national survey. So this is a brief overview of what we'll be talking about. We'll look at the definition of chronic pain and how it affects patients' lives. We'll see how the study was done, and further on, we'll see how move on to the results and the conclusion. So the question arises that why is pain so important? So according to literature, it is the most common presenting symptom due to which people seek medical help. A figure of up to 20% has been quoted to describe its prevalence. But the region where we live, it has been highly neglected for a long time now. Not only is there a shortage of specialized centers, we also lack any large-scale data on the topic. So to define chronic pain, any pain that lasts for 6 or more months after the causating factor has been removed is termed as chronic pain. And not only these patients suffer from physical symptoms, there is psychological problems as well, which can also lead to suicide in some of the cases. So as the saying goes, the first step in solving the problem is to recognize that there is one. And our problem was that we didn't even know the magnitude of the issue that is chronic pain in this country. There have been no nationwide studies which could lead us in a direction where we even begin to start solving this problem. So in light of all of this, we devised this observational cross-sectional population-based survey. We interviewed all the individuals who were coming to Shaukat Khanum collection lab collection centers nationwide. So we covered around 82 plus cities throughout the country. So naturally, we couldn't do this alone. So we needed manpower as well as expertise. So a research company was hired to do the job for us. The budget was provided by STSP Pakistan, and it was around 1 million rupees. Our objectives were fairly simple. We wanted to determine the prevalence of chronic pain in Pakistan, describe pain characteristics and the conditions which are causing this pain. We wanted to identify the types of therapy involved to treat pain and the impact that pain has on patients' lives. So a total of 15,447 people were contacted, out of which 4,801 agreed to participate in the study. So the response rate came out to be around 30%. The prevalence of chronic pain in Pakistan is around 15.7%, which means every 1 in 7th Pakistani is suffering from chronic pain. And if we apply this figure to the overall population, an estimated population of 25 crores, then roughly 3.9 crore people are suffering from this ailment in the country. So I'm sorry, but there are going to be a lot of graphs here because there is a huge amount of data that needs to be shared. So the first graph here shows the average pain intensity on the numerical rating scale. 69% of the affectees were males. But the most alarming stat in this figure is the age distribution, which shows that 65% of the population was aged 47 or less. So the majority of our population, they suffer from chronic back pain and chronic leg pain. 40% reported that it was constant, while 60% said it was intermittent. When it comes to the character of pain, 44% said the pain was sharp, followed by dull and stabbing pain. At its worst, 35% said that the pain was 8 or more on the numerical rating scale. So the majority of these patients never visited a doctor in the last 6 months. Although the ones who did, they reported that they felt comfortable when dealing with the patient, with the doctor. Again, 75% of the patients said that they were satisfied with the doctor, and the major factors for dissatisfaction was ineffective medication and unsatisfactory examination. 56% of the population said that they aren't getting any treatment for their pain. Only 282 patients out of 757 were taking medication, and that also only 2 pills or less than 2 pills per day. So when asked, is your pain relief medication effective? 67% said yes, 23% said partially effective, while 9% said not effective. 84% of the population said that the pain is still not completely controlled. And this slide here shows again the failure on our part, as more than 36% of the patients said that their pain wasn't completely controlled until a year or more. So when asked, have you ever been to a pain management specialist in the last 6 months? A staggering 93% said no. So for me personally, these next 3 slides are the most heart-wrenching of them all, as they focus on the psychological as well as physical effects of chronic pain. 56% of the population said that pain affected their daily functioning. 64% of the patients were suffering from low mood, and 33% were diagnosed with depression by a clinician. 41% were somewhat dependent on others, and 58% were suffering from insomnia. When asked if they ever avoided pain medication because of the fear of its side effects, 49% said yes. 54% were currently unemployed. Have you ever felt so much pain that you wanted to die? 106 patients said yes. Would you be willing to spend all your money on a treatment if it could relieve your pain? 455 said yes, they would. So to conclude, as we have seen from the presentation, the most important factor lacking is education of the masses. The patient once in the clinic must be treated as a whole rather than just treating pain. And we need to encourage more work in this field that we are still lacking behind a lot when compared to the other countries. So I'll end my presentation with a quote from the Holy Quran. May God Almighty end these suffering. Thank you very much.
Now I request the next presenter, Dr. Kenan Anwar Khan from PNS Shifa. The topic is achieving excellence through self-reliance in times of global challenge.
Bismillah ar-Rahman ar-Rahim. Honorable guests, worthy seniors, and my aspiring colleagues, Assalamu alaikum. My name is Dr. Kenan Anwar Khan, and I am resident anesthetist at PNS Shifa Hospital, Karachi. The topic of my presentation is achieving excellence through self-reliance in times of global challenge. The sequence of my presentation will be as flashed. The objective of this presentation is to highlight the challenges faced in the development of indigenously developed Pak Vent 1 ventilator at the height of COVID-19 pandemic in Pakistan. The outbreak of COVID-19 global pandemic posed great challenges to worldwide healthcare systems and had far-reaching socio-economic consequences. According to World Health Organization, and as of 15th of March 2022, there have been around 45 million documented cases with 6 million deaths globally. In Pakistan, we have had 1.5 million documented cases with around 30,000 deaths. With increasing demand and limited availability of ICU ventilators at the peak of the pandemic, Government of Pakistan initiated a drive for manufacturing of indigenous ventilator systems in Pakistan. As a result, under the umbrella of National Command and Operations Center, National Engineering and Scientific Commission developed a prototype medical ventilator designated as ParkVent-1. Engineering design validation and testing of ParkVent-1 was carried out at Pakistan Engineering Council on a fluke. Guidelines and consent forms for human trials were prepared by National Bioethics Committee. Clinical trials of ParkVent-1 were carried out at Combined Military Hospital Rawalpindi, after which the Drug Regulatory Authority of Pakistan approved ParkVent-1 for commercial manufacturing. The study design was human clinical trials, which were conducted between August 2020 to May 2021 in the main operation theater and surgical intensive care unit under the patronage of Major General Dr. Rao Ali Shan Khan, consultant anesthetist and advisor anesthesiology, Pakistan Army. The trials were conducted under the supervision of Professor Brigadier Dr. Ahmed Mujaddid Khan Barki, consultant anesthetist and intensivist, and Dr. Ali Aftab, senior registrar anesthesiology. The selection criteria included Young American Society of Anesthetists Class 1 patients in main operation theater and hemodynamically stable, electively ventilated patients in ICU, as per clinical validation pro forma provided by National Bioethics Committee. Consent was given by patient himself in OT settings and by the next of kin in ICU. Consent form was read aloud and displayed to the patient and next of kin before start of the procedure. The consent form, which was provided by National Bioethics Committee, is displayed with the use of ParkVent-1 ventilator on the patient under controlled environment and strict supervision was mentioned. 9 ventilatory modes categorized into 3 types, that is pressure, volume, and non-invasive modes of ParkVent-1 were tested. Medicines and Health Regulatory Authority of United Kingdom's protocols for approval of new technology were followed throughout the testing phase. Clinical data obtained by medical team and technical data obtained by the engineering team was shared and meticulously scrutinized under strict vigilance. Calibration errors and technological shortcomings were fixed, ensuring no harm to the patients. A statistician was hired to analyze the data and provide results. During testing of ParkVent-1, a standby internationally manufactured ventilator was kept as a backup in case of any eventuality. This is the clinical validation protocol pro forma provided by National Bioethics Committee, which included date and time, patient's detail, relevant clinical information, baseline vitals, arterial blood gases, and ventilatory parameters, which were continuously monitored and regularly documented at predefined intervals throughout the course of the clinical trial. This picture is from one such trial in the main operation theater, where ParkVent-1 is being used to ventilate a patient under TIVA in the presence of medical and engineering teams. Coming on to the challenges, obtaining consent was the most challenging obstacle, as many patients and attendants refused to participate in human clinical trials due to the fear and phobia of COVID-19 at its height and uncertainty and lack of confidence in locally developed machine and technology. Furthermore, during initial trials, there was clinically relevant dyssynchrony between the patient and the machine during patient's voluntary breathing effort. Furthermore, sometimes the PEEP delivered or generated was not as set by the operator. In addition, earlier trials revealed that the FiO2 set and delivered by the machine was different as checked by oxygen analyzer. The same issue happened with tidal volumes which were set and delivered. All these errors were corrected by the team of engineers with tweaks to the software system and minor hardware adjustments. Additional alarm systems were then incorporated in the design, which are now 25 in number, and a backup battery supply was improved. Park Vent 1 now has a battery backup of up to 60 minutes. Human clinical trials were done on 50 patients with a total ventilatory support time of 395 hours. All the modes were thoroughly tested as per National Bioethics Committee approved clinical validation protocol. The performance of Park Vent 1 was satisfactory with a different group of patients and different diseases. The Drug Regulatory Authority of Pakistan approved Park Vent 1 for commercial manufacturing in June 2021. Salient features of Park Vent 1 are as flashed. It can be operated on standard power supply. The upper and lower limits of ventilatory parameters incorporated in the system can be appreciated along with real-time waveforms of pressure, volume, and flow. Park Vent 1 is operated with an oxygen supply of 2 to 4 bar and ambient air supply. I would like to conclude my presentation by saying that the outbreak of COVID-19 pandemic crippled worldwide healthcare systems, but at the same time, this pandemic ignited a strong drive for creativity and innovation. Park Vent 1 is one such noteworthy achievements of our nation in its stride for achieving excellence through self-reliance. Thank you. The House is open for discussion, please.
Thank you very much. As you mentioned that there was ventilator dyssynchrony, especially when the patient started breathing. So was it very, very frequent or just happened occasionally? Because this is something very serious.
So initially, as the ventilator was used on the patient, the synchrony was noted immediately because the vent was trying to deliver breaths and the patient was trying to take his own breaths. So we immediately informed the treatment team, the engineers, and they disconnected the vent. They worked on it for a couple of days, and there was some minor software adjustment. They did that, and in the next trials which we did, there was no dysynchrony.
So there were always fine tuning going on.
Sorry, sir?
So there was always some fine tuning going on by the engineers. Setting again. Okay.
Sir, Assalamu alaikum. I was the supervisor, and PMO engineers were on the floor 24/7, and they were upgrading all the algorithms. So initially it was, we were unable to synchronize the ventilator, but we have incorporated the sensitivity, and now there is no issue of any synchronization. It's all right.
Thank you very much.
Thank you.
Thank you.
And please. I think Gaur also has a question. Huh? Gaur has a question and I have a very small question. You said one of the modes that you could use on it was pressure support, but you didn't mention trigger anywhere or sensitivity anywhere, or did I miss it? Because you can't have pressure support without triggering. If the patient doesn't breathe, pressure support is not, it can't be given.
Yes.
One. Secondly, you did not also mention the modes. Like, was SIMV and assist control both available, or was it just assist control? Right.
Madam, initially, all the modes are incorporated. Assist control is here, and volume and pressure modes are also there. And sensitivity, I think you forgot to mention, it is incorporated, because without it, pressure support ventilation to ho nahi sakti. So isliye it was included.
Thank you very much for sharing your innovation. So one of my questions was covered by Dr. Saida, because I was also asking about the pressure support. So actually we were interested how many patients you were ventilated through this one, and what was the outcome? So number of patients, and are you still using that, and what is the implication now?
Okay.
What's happening with that ventilators?
The outcome of those ventilators, ma'am.
जी, आपने कोई patient उस पर डाला होगा ना?
They have been.
What was the outcome like?
Yeah, basically they have been approved for commercial manufacturing by Drug Regulatory Authority of Pakistan, and NESCOM has issued a tender for the placement of orders of these ventilators in newspapers. So any company or any hospital, if they want to acquire these ventilators, they can approach NESCOM through their proper website and proper channel.
आपके पास कोई अपना experience नहीं है using that ventilator on patients?
Madam, we have got the experience of using it.
हमें वही तो
on-
पूछ रही हूँ उनसे because he is
हाँ,
presenting now, that's why I'm asking you.
नहीं, Madam, I was the supervisor. na,
जी जी
if you
जी
allow
जी
me
जी
to.
जी जी
50 patients were ventilated on his initially. Madam, जो ASF 1 थे ना
हाँ.
और जो कि ऑपरेशन थिएटर में थे, उनके ऊपर हमने इस्तेमाल किया. There were about 15 patients. अपेंडिक्स के थे, हर्निया के थे, फिर उस पे किया
elective surgery.
ताकि हम लोग थोड़े से कॉन्फिडेंट हो जाएं. उसके बाद फिर हम इसको आईसीयू में लेके गए और आईसीयू के अंदर सर those patient who were not very sick, आइनोट्रोपिक सपोर्ट पे नहीं थे, इलेक्टिव वेंटिलेशन पे थे, इनिशियली हमने उस पे इस्तेमाल किया. उसके बाद फिर ARDS एंड फर्दर जो कि सुएज सेप्टिक हो, ARDS हो, उसके ऊपर इस्तेमाल किया. एंड और NBC की जो भी रिक्वायरमेंट थी उसको उसने अचीव किया. इसलिए फिर अल्टीमेटली इट वाज अप्रूव्ड एंड इट होल्ड took about 2 years. 2 साल हमें लगे हैं नाइट इसके ऊपर सारा.
Assalamu alaikum. My name is Dr. Tabish. I am from Trauma Center. Okay, I have a question for you. These ventilators were specifically meant for COVID patients, and we all know that COVID leads to ARDS. ARDS में we have seen that hypercapnia होता है, patient CO2 retain करता है, and we need to maintain high respiratory rate. हम लोगों को high respiratory rate set करना पड़ता है ventilator पर. Over here, I can see that the respiratory rate on these ventilators has a very narrow limit, 8 to 35. And I ratio is also very narrow. Sometimes we need to go as far as 40 breaths per minute, or I ratio we have to set above 1:3. So what do we do in these conditions?
These are the specifications which has been given by NESCOM, and these are the specifications upon which the alarms are triggered. Definitely, well, the ventilators we use in the ICUs, if we switch on the alarms, we can up and increase the inspiratory-expiratory ratio as well as respiratory rate. So that can also be incorporated. These are the normal values upon which the alarms are triggered as per default by the system.
Thank you.
I think we have to proceed because we are running short of time. The next topic is to evaluate if dexmedetomidine infusion has a role in renal protection in post-CABG patients, a randomized controlled trial. Dr. Sajjad Ahmed, NICVD.
Bismillahirrahmanirrahim. I'm Dr. Sajjad Ahmed, Year 2 resident, NICVD Karachi. Our topic of study was to evaluate if dexmedetomidine infusion has a role in renal protection in post-CABG patients. The incidence of cardiac surgery associated acute kidney injury varies from 5 to 42% internationally. This percentage was found to be 7.86% according to study conducted in Pakistan. Severe cardiac surgery associated AKI independently associated with 3 to 8 folds higher perioperative mortality, prolonged ICU stay, and it will automatically increase the length of hospital stay. Yet there is no definitive strategy for preventing AKI after cardiac surgery. Dexmedetomidine is a selective and potent alpha-2 adenoreceptor agonist that is used for anxiolytic, sedative, and analgesic properties. Now there is increasing evidence of its organ protective properties against ischemic and hypoxic injury, including neuroprotection, cardioprotection, and renal protection. The objective of our study is to follow and compare the changes in serum creatinine levels and urine output up to 48 hours of surgery in patients receiving dexmedetomidine infusion in addition to standard protocol as compared to the patient who are receiving standard protocol alone. Before going into details, let's have operational definition of AKI. If there is increase in serum creatinine levels more than 0.3 milligram per deciliter within 48 hours, or urine volume of less than 0.5 mils per kg for 6 hours, we can label it AKI according to protocols taken from kidney disease improving global outcomes. All patients who are included range between 18 to 65 years, undergoing isolated coronary artery bypass grafting. They were classified as ASA4 physical status. All patients with preoperative renal impairment, diuretic use, pre-existing hepatic, pulmonary disease, peripheral vascular disease, previous cardiac surgery, emergency surgery, reopening surgeries, and surgeries requiring deep hypothermic circulatory arrest, preoperative use of inotropes or vasopressors, they were excluded. All patients with perioperative use of diuretic, perioperative episode of CPR, preoperative hemoglobin level less than 12 gram per deciliter, having hematological disorders or morbidly obese, they were also excluded. This study was conducted in the Department of Anesthesia and Intensive Care in National Institute of Cardiovascular Disease, Karachi, for the period of 6 months. Total number of patients were 60, 30 patients in each group. The group C was control group, and group D, who is the number of patients who received dexmedetomidine infusion as a continuous infusion at a dose of 0.4 mics per kg per hour for 24 hours from the time of induction. It was a randomized control trial. The sampling technique was non-permeability sampling. The data was analyzed using SPSS Orient 21. The treatment and control groups were compared for baseline characteristic and outcomes by conducting chi-square test and independent sample t-test. Two-sided p-values of less than 0.05 taken as a criteria for significance. Data was collected after the approval from the ethical committee of the hospital. All patients were involved in the study after informed and written consent. In the operating room, wide-bore intravenous cannula was inserted. Midazolam was given as a pre-medication. Radial artery cannulation under local anesthesia was done. Oxygen saturation, heart rate, and invasive blood pressures were monitored. Anesthesia was induced by propofol, nalbuphine, and atracurium. The doses of induction was adjusted according to the hemodynamics and myocardial function of the patient. Following pre-oxygenation for 3 minutes, a suitable size endotracheal tube was placed and the patient connected to anesthesia machine. Anesthesia was maintained with an inhalation agent. After the induction of anesthesia, central venous line urinary catheter put in and temperature probe was inserted. ABGs was done to show serum sodium and potassium hematocrit. Blood glucose levels was measured after induction of anesthesia during bypass time, weaning from bypass, and according to needs. ACT was measured at baseline 3 minutes after heparin administration during bypass time, finally after the reversal of heparin with protamine sulfate. The primary outcome of our study was to affect on the serum creatinine levels, that is measured in milligram per deciliter at baseline, 24 hours and 48 hours. The secondary outcomes were amount of urine output per hour up to 48 hours after surgery, duration of ICU stay, dosage of inotropes and hemoglobin levels at baseline, at 24 hours and at 48 hours. Variables such as operative time, aortic cross-clamp time, and bypass time was taken into account. Here are results. The demographic between two groups were comparable and remain insignificant as far as concerned for p-values. The table 2 is important one where the baseline serum creatinine levels in control group was 0.96 as compared to dexmed group where baseline serum creatinine levels was 0.76 with variation. After 48 hours, the serum creatinine levels rose significantly up to 1.38 milligram per deciliter in control group, whereas in dexmed group, the serum creatinine levels remain static, almost static. That is 0.82 milligram per deciliter. In the end, the p-value came out to be significant, that is less than 0.001. It is pertinent to mention over here the urine output values remain insignificant as far as the p-value is concerned. The dosage and duration of inotrope and vasopressors again are insignificant as far as the p-value was concerned. The episodes of hypotension and bradycardia again was insignificant as far as the p-value was concerned. This graph shows the trend of serum creatinine levels from the baseline up to 48 hours. On the y-axis, there is serum creatinine levels, and on the time is taken on the y-axis. The blue line depicts the control group. Here we can clearly see the uprise trend in the serum creatinine levels up to 48 hours. And the green line depicts the dexmed group. Here we can see that there is no significant difference up to 48 hours in serum creatinine levels. This bar chart shows the AKI, the number of patients who are positive for AKI according to the operational definitions. The 13 patients in control group are positive for AKI as compared to dexmed group. Only 3 patients were positive. That connects 10% of the patients who are positive. The p-value was 0.004. This is single standard placebo-controlled randomized trial. Dexmedetomidine reduced AKI after cardiac surgery, which is associated with significant
morbidity and mortality over the longer term. The study is amongst the few studies to suggest renoprotective role of dexmedetomidine in patients undergoing CABG surgery. However, randomized clinical trials addressing positive renoprotective effect of dexmed having shown conflicting results, which were mainly ascribed to the heterogeneous dosing and timing of dexmedetomidine administration. One of the main contributing factors is causing renal derangement post-CABG. It is related to sympathetic hyperactivation and renal hyperperfusion. During general anesthesia, there is further reduction in renal blood flow and perfusion supporting a potential role of a sympatholytic agent in mitigating renal injury. Due to its high prevalence and poor prognosis, therapies aimed at preventing AKI after CABG would deserve a high priority. In that context, dexmedetomidine may be promising agent for preventing AKI. Dexmedetomidine not only attenuates sympathorenal hyperactivity and reduces plasma level of catecholamines in cardiac surgical patients, but additionally induces nitric oxide dependent vasorelaxation mediated by activation of endothelial alpha-2 receptors. Dexmedetomidine reduces systemic inflammatory responses, reactive oxygen species generation, that is ischemic and reperfusion injury associated renal cell death involving attenuation of major inflammatory mediators. During the immediate post-operative period, where usually within 24 hours, inflammatory reactions and sympathetic activation accompanying hemodynamic instability and major organ damage are prominent. So that's why we'll continue our infusion up to 24 hours. There are a few limitations to our study. Firstly, it is a single standard study. Secondly, it was done in the preserved cardiac and renal function. Simultaneously, we did not assess the level of plasma catecholamines and inflammatory markers. We concluded the administration of dexmedetomidine for 24 hours after starting at the time of anesthetic induction reduces the incidence of AKI after CABG. Following are the references. Thank you.
Thank you very much, Dr. Sajjad. Any question? Thank you. Now, Dr. Bilal Chand from Aga Khan University Hospital. The topic of the presenter is comparison of morphine with nalbuphine in multimodal approach for pain relief in patients undergoing gynecological procedures, a randomized controlled double-blind trial. Bulge. Sorry, bulge.
Assalamualaikum everyone. My name is Dr. Balchan Guraya, Department of Anesthesia Department, Aga Khan University Hospital, resident year 5. So today's my topic is comparison of morphine with nalbuphine in a multimodal approach for pain relief in patient undergoing gynecological procedures. It's a randomized double-blind controlled trial which was conducted at Aga Khan University Hospital. So based on the introduction of the topic, intravenous opioids are commonly used agents to provide analgesia during general anesthesia and in the immediate post-operative periods. Currently, Pakistan is facing critical shortage of morphine for pain control. We strongly feel the need to have an alternative of morphine in our population to provide adequate pain control. So this was the reason we conducted this study. A large number of patients undergoing major surgical procedures need gold standard analgesia like morphine for adequate pain control. Shortage of morphine results in inadequate pain relief, leading to delayed recovery, prolonged hospitalization, and persistent post-surgical pain syndrome. For better surgical outcome, there is a strong need to have an alternative of morphine in a multimodal analgesia that help optimize pain. So what was the primary object of the study? It was study to compare analgesic requirement of nalbuphine with morphine in a multimodal analgesia in patient undergoing gynecological procedures, especially open gynecological procedure like total abdominal hysterectomies. So in a multimodal approach using with paracetamol and ketamine. Second, the objective was to look out at the adverse effects associated with morphine and nalbuphine. So how this trial was conducted? This trial was conducted in October 2019 till October 2020 during the 1 year period in the operating room and the surgical ward of the Aga Khan University Hospital. After taking approval from clinical trial unit and ethical review committee of Aga Khan, total of 66 women scheduled for total open abdominal hysterectomy were enrolled for this procedure. A conduct of study. After taking consents and approval from CTU and ethical review committee, we conducted this study. Standard general anesthesia was given with intravenous ketamine 0.3 mg per kg, study drug 0.1 mg per kg of body weight, which could be nalbuphine or morphine, and propofol 2 mg per kg, followed by intubating dose of atracurium, which was as 0.5 mg per kg. So these all agents were given for maintenance. We use isoflurane to make a 1.2. And after monitoring pain, we patient extubated and shifted to the recovery room. In the recovery room, patient control analgesia, PCI of study drug was started at 1 ml bolus, 10 minutes lockout time, and 1 ml background infusion up to 24 hours. Intravenous paracetamol and in 24 hours was given also every 6 hours. Patient's pain was using numerical rating scale at different study timings in the recovery room and in the surgical ward for 24 hours. Post-operative nausea, vomiting, and traditional scores were also monitored by using numerical rating scale and post score. How the data was analyzed? Data was entered and analyzed using SPSS version. Normally distributed continuous data were expressed as mean and standard deviation. Non-numerically distributed data as median and interquartile range. Frequency and proportional were expressed for categorical data. Analgesic requirement between two groups, nalbuphine and morphine, were measured using chi-square test, whereas pain score in two groups was compared using student's t-test. So result of study. A total of 66 patients were recruited in 1 year, starting from October 2019 till 2020. After removal dropouts, we have 2 dropouts because surgery was planned, but at the end time, due to surgeon unavailability and some issues, 2 patients were dropped out. 32 patients were in each group were screened to analyzed. The average age and BMI in patients were 40 years age, and BMI was 27.9. This was average age and BMI. Mean age, height, and duration of study and BMI were not statistically significant among groups. As shown in this figure, the weight is approximately 70 in both groups, height is approximately similar, and there is no any demographic or difference between the both groups, nalbuphine group and the morphine groups. These are the frequently comorbids present in the patients. Hypertension was common in both groups. 10 patients in nalbuphine group have hypertension, and 7 patients in morphine group have hypertension. Other one had diabetes, obesity, anemia. They were common among others. So based on the pain score duration, study timing morphine provide better pain control in immediate post-operative period after 1 hour. So according to a study, if we use morphine in open abdominal surgery, it provides better analgesia as compared to nalbuphine if we use an multimodal approach at immediate post-op period. At other timing, both morphine and nalbuphine provide similar analgesia. Nalbuphine consumption in terms of mass of the drug was more than morphine, but difference is not statistically significant with p-value of 0.60. None of the drug was shown any adverse effects, and frequency of adverse effects are similar in both groups. So this was shown in chart. In the recovery room, the mean pain score in both groups was 3.8 and 4.9, but at initial it was not study significant. But at 1 hour in the recovery room, it show a significant difference of 3.2 in morphine group, and in nalbuphine it was 4.47, which was a p-value of 0.026. But otherwise, in the ward, there was no any significant results. Total consumption, approximately 45.97 mg was consumed in morphine group, and in nalbuphine it was 48.23, which is not insignificant. So consumption was more in nalbuphine group as compared to morphine group, but there is no any significant difference. So we conclude, this study conclude that nalbuphine with ketamine and paracetamol can be used an alternative to morphine in major abdominal gynecological surgery, which there is a shortage of gold standard like morphine. However, future RCTs with large sample size and required for overall outcome in surgical populations. Thank you so much. Any question?
Thank you very much. As we are running short of time, we may take further discussions can be done at lunchtime. So the next topic is anesthetist perception of anesthetist surgeon conflicts in operation theatre. Dr. Maha Batul from Shaheed Mohtarma Benazir Bhutto Trauma Center.
Okay, Bismillahirrahmanirrahim. Assalamu alaikum. This is Dr. Maha Batul, anesthesia resident, Shaheed Mohtarma Benazir Bhutto Institute of Trauma, Karachi. So most of the participants has brought the topics related to clinical research, but I have selected a topic which is quite unnoticeable when it comes to research basis, but is also important to an extent that it is being discussed every other day. So article I selected is entitled as Anesthetist Perception of Anesthetist Surgeon Conflicts in Operation Theatres. So we have a shortage of time, so let's go through the brief introduction. You all know that the OT settings is the most complex and turbulent environment to work, where two co-equal doctors share one patient. So workplaces like operation theaters, where two highly educated and experienced physicians work together, discuss is very common. Why? Because of each person's own thinking, beliefs, and values. They are very different, and they do react different in different situations, which may lead to the conflicts. So in high pressure environments like operation theaters, these conflicts can range from minor to major. That means like from personality clashes to the physical confrontations even too. So coming to the object, our objective is to determine the anesthetist perception of anesthetist surgeon conflicts in the operation theaters. So coming to the materials and methods, it's a cross-sectional study which was conducted at Department of Anesthesiology, Shaheed Mohtarma Benazir Bhutto Institute of Trauma, Karachi, during the period of 1 year, starting from 1st July 2020 till 1st June 2021. Total 50 participants were recruited, out of which 60% were male and 40% were females. And the participants aged between the range of 25 to 55 years. So these are the results. This is the first table showing the demographic variables of the enrolled cases, which was including mean age, and then the working experience, gender, and last one is the marital status. So mean age was 37.68. And on the basis of working experience, those who were having the work experience of greater than 5 years were just 70%. And those with the work experience of less than 5 years were 30%. As far as the gender was concerned, male were 60% and females were 40%. Data collected for marital status showed 80% participants married and 20% were unmarried. Okay, this is the main table of my result that includes those variables. Basically, these are the predictors which we assessed in our study, in our setup, which is including patient's pressure on the surgeon to be operated, then anesthesiologist's instructions being followed or not, then patient's ignorance about the anesthesiologist's role, and the lack of information about the patient's need or knowledge, or lack of coordination of the teamwork regarding the operational priorities, lack of outpatient anesthesia clinic, and lack of work facilities, which is the most important predictor. So I am with a shortage of time, so I will only highlight few results of some important variables. First one is the patient pressure. All of the participants responded no to it. That means my participants believe that there is no patient pressure over the surgeon to get operated too early. Second, another very important predictor was anesthesiologist's instructions being followed or not. So 80% of my participants believe that nobody in the theaters consider their instructions. Okay, another very important predictor is decision regarding the urgency of operation. 92% of participants responded yes to it. They believe that they have this perception that always a surgeon does emergency in operating their list. It's just like an elective case suddenly becomes an emergency. Most of you people have gone through this. Then another very important predictor is lack of an outpatient anesthesia clinic. 94% of the participants responded yes to it. And last but not the least is a shortage of work facilities. All of the participants perceive that, and they were agreed on this point, due to low resources, more conflicts can be created between the anesthetists and surgeons. Okay, coming to the discussion part, I will just thoroughly go through this. In the current healthcare environment, it is very important for stakeholders within a facility to work as a team for optimal efficiency. No relationship is more crucial than that of a surgeon and an anesthetist. Conflicts have been identified as the most stressful aspect of their work by anesthetists. Conflicts in operation rooms can prevent safe and effective anesthetic care, but by resolving these conflicts, we can provide a good patient care or good treatment to the patient. Main reasons of the conflicts have been determined were poor social connection outside the work and the lack of appreciation of the doctors. Physicians generally saw surgeons as a dominant, cold or aggressive or arrogant or self-centered, which can spark the conflict in negative terms, basically. So absence of anesthesia clinic, which is very important, was recognized as a source of conflict. And these pre-op anesthesia clinic have been reported to help the patients, as they can improve the patient safety, patient outcome, pre-operative medical consultation resources, laboratory researches, and hospital stay have also been reduced. Okay, now the conclusion. Basically what we concluded, we have found that in perception of an anesthetist, there are a number of reasons that do exist and can trigger a conflict between the anesthetist and surgeon in the operation theaters. And but we do believe that by digging out these problems for these predictors, we can harmonize the surgeon's workplace with anesthesiologists in future. Okay, these are the references for my study, and these all are taken from the international journals. So thank you for your patient listening. Any queries?
Thank you very much, Dr. Mahabatul. Now, Mr. Muhammad,
thank you.
Dr. Muhammad Wajid Iqbal, Hamdard University Hospital. He will be presenting to determine the effectiveness of spinal anesthesia versus saddle block in terms of hemodynamic stability and vasopressor requirement in TUR.
Thank you very much, sir. Assalamu alaikum.
Please. Swal karna cha rahe hain. Please start.
Thank you. Thank you, sir. I'm Dr. Wajid Iqbal, postgraduate trainee R2 in Hamdard University Hospital, Karachi. And I'm going to present my study, effectiveness of saddle block versus spinal anesthesia in transurethral resection of prostate. We declare none of the conflict of interest. And beginning with the introduction, benign prostatic hyperplasia is one of the most frequent disease among male gender. And its incidence is 50% age, among the age group of 50 to 60 years. And TURP is minimally invasive and gold standard procedure for resection of prostate through endoscopic technique. In TURP procedures, regional anesthesia is extensively applied instead of general anesthesia, because regional anesthesia has various benefits over general anesthesia, including reduced drug usage, avoiding airway manipulation, speedy recovery, early mobilization, and reduced post-operative pain. The saddle block is one of the modality of spinal anesthesia which blocks the lower thoracic and novosacral nerve roots. And so likelihood of hemodynamic instability is lower in saddle block group, resulting in less vasopressor drug requirements. The rationale of our study is to compare the effectiveness of saddle block with spinal anesthesia technique regarding intraoperative hemodynamic stability of patients and to reduce the usage of vasopressor drugs in order to establish the local perspective as there is paucity of data in Pakistan. And achievement of anesthetic goals during TURP with limited hemodynamics instability is the primary goal of any anesthetist. So data from our study will provide valuable information in achieving these goals. The objective of our study is to determine the effectiveness of spinal anesthesia versus saddle block in TURP. Operation definitions, we included our hemodynamic status that is observed on the basis of blood pressure, mean arterial pressure, and heart rate. The parameters were noted from the baseline till end of the procedure. At 5 minutes interval, maximum fall from baseline during these intervals was recorded, and vasopressors was administered in on incidence of clinically significant hypertension, that is mean arterial pressure less than 20% from the baseline. Our hypothesis was that saddle block anesthesia is more effective as compared to spinal anesthesia in terms of intraoperative hemodynamic stability and vasopressor drug requirements. The material and methods, the study was conducted at Department of Anesthesia, Hamdard University Hospital, and study design is open label randomized controlled trial, non-probability consecutive sampling technique, and duration of study is 6 months after approval from ERC, Hamdard University, that is September 2021 till February 2022. And using power of 80% and 5% level of significance, total sample size of 60 patients was calculated and 30 patients in each group were enrolled. We included patients who gave consent and age range from 45 to 65 years and ASA grade 1 and 2. Non-consenting and patient with absolute contraindication of regional anesthesia, deformity of vertebral column, psychiatric illness, neurological disease, and ischemic heart disease were excluded from the study. And the patient fulfilling the inclusion criteria were enrolled in the study, and informed consent was taken, and brief history was taken, and patients were randomly allocated in groups using sealed opaque envelopes. Both groups, patients preloaded with 250 ml of colloid solution, that is the injection gelaflucin, thereafter co-loaded with injection ringer lactate 5 to 10 ml per kg per hour, and 12 mg of 0.5% hyperbaric bupivacaine given intrathecally, that is subarachnoid space, at level of L3, L4 with 25 gauge pencil point tip needle. Achievement of sensory block was considered till T10 level assessed by pinprick method at mid-clavicular line from the time of intrathecal drug delivery till 10 minutes. And achievement of motor block, Bromwich scale 2 or greater than 2 was assessed from the time of intrathecal drug delivery till 10 minutes. In spinal group, spine position was given immediately after injecting hyperbaric bupivacaine, while in saddle block, patients were instructed to sit for further 5 minutes after receiving hyperbaric bupivacaine, and then the supine position was maintained. Hemodynamic parameters were recorded intraoperatively at every 5-minute interval till the end of the surgery. And after completion of procedure, the parameters were recorded at every hour interval till 3 hours postoperatively. That the data was statistically analyzed on SPSS version 21. Chi-square, Fisher-Exact test, independent t-test, man-VTU test were used to compare the variables, and two-tailed p-value less than 5% level of significance was defined as statistically significant. Now coming to our results, when we compare the patient's characteristics among both the groups, this shows that there is no difference in the patient characteristics like age, body weight index, and duration of surgery, ASA status, and baseline clinical parameters. They lie in the same median in both the groups. Now, when we compare the hemodynamic parameters among both the groups, that is the fall of from the baseline, that showed that systolic blood pressure significantly dropped from the baseline, that is 24.4 from the median, while the saddle block, it is 13.4 median. It shows significant p-value. Likewise, the diastolic blood pressure and mean arterial pressure and pulse rate, they also significantly drop from the baseline in saddle block groups, while there is not a significant drop in saddle block group. one more hemodynamic parameter that we studied with the time duration, that in initial 20 minutes, there is a significant drop from the baseline in the hemodynamic parameter like systolic blood pressure and diastolic mean artery pressure per set in both the groups. But there is also the spinal block group has more significant drop as compared to saddle block group. And the vasopressor requirement, another finding, 12% of the patient in spinal block group required vasopressor drug usage, while none of the patient in saddle block require vasopressor drug usage. So coming to the discussion, intraoperative morbidity in TURP procedures varies from 18 to 26%, with the highest death rate is 1%. Intraoperative hemodynamic instability after spinal anesthesia is common. Incidence of intraoperative hypertension as low as 8% and as high as 33%, relying on the number of parameters involved in defining hypertension. And intraoperative hypertension is a matter of concern in spinal anesthesia, which has even the potential to cause death. It usually occurs within 10 minutes of administering the drug, and majority of the fatalities occur in this crucial time. Our findings are similar to the studies carried out by Indian researchers like Bhattacharya et al., Bijoy et al., and Chatterpal et al. So now as a conclusion, saddle block is one of the safest technique for TURP procedures with controlled hemodynamic status in comparison to spinal anesthesia. Moreover, saddle block requires less vasopressor consumption than spinal anesthesia technique. So we can say that saddle block provides clinically effective surgical anesthesia for TURP as an alternative to approach to spinal anesthesia. These are the references. Thank you very much.
Just one comment. When you're saying saddle block anesthesia, it strictly means blockage of S234.
Yes,
right?
sir. Means lower.
And you were saying that spinal in both of them, the blockage was up to T10. So how do you think that T10 blockade was achieved? Because strictly speaking, when you say saddle block anesthesia, it means blockage of the pudendal outflow.
Will do, sir. Yes, sir. Any other question? I'm saying that the saddle block, it blocks lower nerve roots, like lumbosacral nerve roots, especially. Yeah, sacral and lower lumbar and sacral nerve roots in saddle block. They are covering the perineal area. Yes, sir.
S3, 4, and 5. Maybe S2, but the ventral part of penis and the nerve supply of bladder is T9 and 10. What is the difference between saddle and lower spinal?
Because in lower spinal, we reach up till T10 level, while in saddle block, it is more denser in the, especially in the sacral area, means that is S2, S3, and S4 levels, that is supplying the perineal area. So because the difference that the lumbar portion is not that much disturbed, that it can means the autonomic.
Two fundamental questions. TURP required what level of anesthesia?
Sorry, ma'am?
TURP required what level of anesthesia?
TURP,
क्या level achieve करना चाहते हैं to have a successfully done TURP?
TURP actually requires the level of lower lumbar and sacral, especially the sacral, and from L5 to S3.
आप assess करते होंगे ना मरीज को what level you want to achieve. This is the level I want to achieve before starting the surgery. T8, T9, T4, L1 क्या level चाहते हैं?
We took it as T10 level, up the umbilicus level.
So देखो अगर saddle block में lumbar block करो तो that's not a saddle block. ठीक है, सैडल ब्लॉक से लंबा नहीं होना चाहिए ब्लॉक. सैडल मीन सैडल, दैट इज एडवांटेज ऑफ सैडल,
Sure.
है ना, इसलिए उसको हाइपरटेंशन वगैरह नहीं होता ना. सो आई थिंक देयर इज सम कुछ उसकी कोई कंफ्यूजन है. ठीक है,
Well, there
सैडल
is-
मीन सैडल.
Were you satisfied when they were irrigating afterwards? Irrigating the bladder after TURP? Were you satisfied? I think you had only one thing in mind to compare it, blood pressure.
Yes, sir.
Because after that, they do irrigation in the ward or any recovery area. Patient must be very uncomfortable with the saddle problem.
We actually did
ये भी
with
एक
the
पैरामीटर
hemodynamic
साथ रख
parameters.
लेते तो बेहतर होता.
We did actually just compare the hemodynamic parameters and vasopressor drug usage.
Otherwise, it's a
Okay,
good comparison.
Okay, I think we have to proceed to the next participant.
Thank you.
Thank you very much. I would like to invite now Dr. Asif Hassan from the Indus Hospital Network, and his and his topic is application of standard informed consent procedure among practicing anesthetists in tertiary care hospitals of Karachi, a cross-sectional survey. Well, you seem to be quite popular, seeing the.
Assalamu alaikum everyone. I am Dr. Asif Hassan, R3 resident in Indus Hospital, and I will be presenting a research work on application of standard informed consent procedure among practicing anesthetists in tertiary care hospitals of Karachi. So first of all, we should know what is consent, why it is important, and what are the benefits of informed consent. Consent is an autonomous decision making by a patient which allows him or her to think, decide, define, and protect their interests and personal privacy. It is a process by which a healthcare provider educates the patient or his attendant about the medical treatment procedure. It consists of knowledge about the risks and benefits about the procedure. The benefits of informed consent: it protects the patient's right of self-determination. It engages the patient in their healthcare, enhances the patient-physician relationship, and it encourages the physician to thoroughly review the patient's therapeutic options and reducing discontent and litigation when there are complications. The rationale behind conduction of the study was that finding out the standard of the consent applied will help in better understanding and learning of the consent process and will ultimately build the doctor-patient relationship. Our objective was to determine the frequency of anesthesiologists who are practicing standards of consent. Operational definitions: informed consent is a standard process which generally includes information about anesthetic technique, effects of drugs, alternative technique if one fails, and specific aspects related to the procedures and its risks. Practice of standard was assessed through a self-made questionnaire which comprises of total 16 questions, each having 5 options: always, some of the time, most of the time, never, and rarely. And each have its specific score from 0 to 4. The total score was 64. The range of his score was 64, and a score below median, that is 32, was considered as unacceptable practice of standard, and above 32 or equal to 32 was considered as acceptable practice of standards. It was a cross-sectional study. It was conducted in tertiary care hospitals as Indus Hospital, AKU, Civil Hospital, JPMC, and NICVT. It was conducted for 6 months from 15 Feb 2021 to 14 August 2021. Sample size was calculated by Open EPI calculator version 3.01. The level of significance was taken as 95% with the margin of error of 9%. The sample size was calculated using the frequencies of self-designed tool assessing practices of obtaining consent among practicing anesthetists. These are different variables which were used in the calculation of sample size, and sample size was taken as 112. So the inclusion criteria: consultants, specialists, FCPS residents with a minimum of 2 years of experience in anesthesia, and those who agree to participate, and either gender. MCPS residents and first and second year residents of FCPS were excluded from the study. So study was conducted after the approval from CPSP and IRB of the Indus Hospital. The eligible anesthesiologist was approached and was asked for the consent to participate in the study. Those who agreed to participate was given the questionnaire and it was filled and then was returned to the PI or study team member on the same day. As I previously mentioned, the assessment was done through a self-made questionnaire, which have five options for each question and each scoring from 0 to 4. Total score was 64 and score below median 32 was considered as an unacceptable practice of standard and above median or equal to 32 was considered as acceptable practice of standards. Data was analyzed by using SPSS version 24, descriptive analysis for demographic details was done. Quantitative data such as age and years of experience in anesthesia was presented as mean or median after normality assessment. Frequency and percentages was calculated for categorical demographic details such as gender, qualification, and current hospital of employment. The practice of consent taking responses from anesthetists is presented as frequency and percentages. There were two sections of the questionnaire. Section 1 assessed the timing, influences, and concerns regarding obtaining consent, whereas the other section assessed disclosure of risk, benefits, and alternative forms of anesthesia. The score of each of the participants from these two sections was summed out of 64 and divided between two groups. Chi-square test was used. Effect modifiers were controlled by stratifying on age, gender, and years of experience. Post-stratification chi-square was calculated. A p-value of less than 0.05 was considered statistically significant. So these are the results. A total of 112 participants were included, out of which 111 were practicing standards. Average age of the participants was 34 plus minus 8.15 years, and average experience was 5.43 plus 5.9 years. There were 64% female participants and 36% males. Most of the participants were residents and 46.4% were from public sector and 53.5% were from private hospitals. So this is the gender distribution. As I mentioned, 36% males and 64% females. This is the qualification of participants, with the most 69% being the residents and the other FCPS qualified consultants and MCPS or diploma specialists. Type of hospital, as I mentioned, public hospital 46 and private hospital 53%. So this was the questionnaire. I will not read the whole of it, just I am showing here. It was divided in two sections. Response of practice of obtaining consent. Section 1 was assessing timing, influences, and concerns. It is also the continuation of the same section. And this was the second section, which assessed the response of practice of obtaining consent, disclosure of benefits, risks, and alternative forms of anesthesia. It is also the continuation of the same. In conclusion, the current practice of obtaining informed consent only assesses the nature and type of anesthesia to be provided. Patients were inadequately informed on the rare risks related to anesthesia and alternative forms of anesthesia. A written consent form for anesthesia that fully outlines the anesthesia, its possible risks and benefits, as well as alternatives to the proposed form of anesthesia should be developed. That was all about. These were the references. Thank you.
Thank you very much.
Thank you.
Thank you.
Okay, this concludes our resident free paper contest. Now we are going to announce the poster prize ceremony. We're going to have that. And I would like to request the jury to come on stage. Professor Dr. Safia, Dr. Mohsin, and Dr. Saad Kaftab. And I would like to request Professor Dr. Fawzia Anis Khan to please come on stage as well.
अच्छा, इट इज अ वेरी गुड न्यूज के बहुत सारे लोग जो है ना रिसर्च में इन्वॉल्व हो गए एंड दिस इज वेरी गुड, क्योंकि जब व्हेन वी हमने स्टार्ट किया था ना, वेरी फ्यू पीपल वर इन्वॉल्व इन रिसर्च. Nearly about 9 papers were for presentation and 33 के बदले में 31 पोस्टर मिले. अब हम लोग तीनों ने वो किया है. दिस इज वेरी गुड एंड पेपर्स वर वेरी गुड. इट वाज वेरी डिफिकल्ट टू मेक अ डिसीजन, लेकिन बहरहाल हमें स्कोर तकरीबन 0.2 0.5 इतना फर्क पड़ रहा था. तो जस्ट टू अनाउंस, थर्ड करें. अच्छा, ये है जो नंबर 3 है, वो 4 लोग आ रहे हैं. बिल्कुल 15.2 जो है ना स्कोर है. तो ये पहले के मैं थर्ड के बता देती हूँ. नंबर 3 के अस्मा रेयानी, और वलीद. हाँ, आ रही हैं? कौन है? अस्मा रेयानी. ये आ रही है. हाँ, वलीद बिन गफार. वलीद बिन गफार. वलीद आ रहे हैं? वलीद आ रहा है तो और बुला लें. राव, नुमान एंड सिद्रा इकराम. ये 4 लोग हैं. नंबर 3. वलीद आ गए? नहीं, वलीद. अच्छा, 3 आए हैं 4 में. ओके. नंबर 2 हबा अहमद. नंबर 1 का बताते हैं. नंबर 2 इज हबा अहमद and number 1 is Umar Iqbal Butt. इंस्टीट्यूट हमने लिखा नहीं था.
वलीद थे, कहाँ के थे वलीद? ट्रॉमा के. और अभी ये सीएच के किए हैं. हबा,
ये नंबर 2 है ना. हबा, हबा है ना. और उमर इकबाल.
हबा सेकंड प्राइज फ्रॉम सीएच के.
उमर इकबाल बट is number 1.
उमर इकबाल फर्स्ट प्राइज पोस्टर. उमर इकबाल नहीं. उमर इकबाल लाहौर से, जिना हॉस्पिटल लाहौर.
चले गए.
ओके, दे देंगे उनको, भिजवा देंगे किसी को.
चले.
थैंक यू. पोस्टर सेशन में एक चीज मैं बता दूं कि जब इनका कर रहे थे तो 0.2 0.4 का भी फर्क था. जिनको थर्ड मिला है वो 4 लोग थर्ड आ गए हैं, और जो अगर हम फोर्थ भी बनाते तो 4 लोग और फोर्थ आ जाते, और 0.2 के फर्क से. तो किसी को दिल छोटा करने की जरूरत नहीं है. बहुत अच्छा आप लोग ने किया था सबने. थैंक यू.
जूरी की भी सर्टिफिकेट से तो वो काइंडली. सर,
डॉक्टर साहब का
सॉरी. कंटेंसेंस के साथ एक तस्वीर भी होनी चाहिए.
डॉक्टर मोहसन. Now I request the second jury, if you are ready, please announce the result.
Sir, first we're going to have sir जो हमारी jury थी अच्छा ready sir आ जाओ. Sir please come on stage. Professor Rishabh.
जी जी आप आ जाएं बताना सर. डॉक्टर हामिद.
Sir would like to request Dr. Professor Tibu Sultan to please come on stage for the distribution of the prize.
कितने प्राइस दे रहे हो भाई?
जी जी आप जी ठीक. Yes, Assalamu alaikum. So it was a very interesting competition between all the speakers. Obviously, everybody made excellent endeavors to research and then present within the limited time. They had so many, obviously, references as well. But the jury with me, we included about 3 people. So it was very difficult for us to decide about the winners. So it's in great excitement. So I'll start from the bottom. And it's a unanimous decision of all of us. Let us see how it goes. So, first winner from bottom, that means number 3, is Dr. Balachan. And in the middle, we have Dr. Hajira Zafar Siddiqui. Then keep your fingers crossed for the final gold medalist, Dr. Sajjad. Congratulations.
First prize.
Well done.
Thank you. First, now we'll distribute the certificates of participation of the
certificate of participation,
jury.
sir.
Sir, please.
Non-probability sampling randomized controlled trial study title first prize possible है.
सर मेरा एक रिक्वेस्ट है थोड़ी सी.
A winner of the poster competition, if you can come on stage, please.
सिर्फ बात इस पे मैं एक छोटी सी आपसे बड़े सीनियर लोगों से राय लेना चाहता था कि जो NICVD से स्टडी प्रेजेंट हुई थी उसमें उन्होंने सैम्पलिंग टेक्निक का बताया था, नॉन प्रोबेबिलिटी सैम्पलिंग. और स्टडी की टाइटल आपने दिया है रैंडमाइज कंट्रोल ट्रायल। तो रैंडमाइज कंट्रोल ट्रायल हो ही नहीं सकता नॉन प्रोबेबिलिटी सैंपलिंग पे, आप नॉन रैंडमाइज कहते। और उसी स्टडी को जब प्राइज मिला तो मुझे खुशगवार हैरत बहुत ज्यादा हुई है। आप देख लीजिएगा इसको।
जब वो जूरी खड़ी है तो हम क्यों नहीं आए? और क्या जूरी को भूल गए।
Now certificates
of
announced
participation. Dr. Wasim Ismail.
Professor Dr. Rana Altaf, your certificate, please. Dr. Hamid Akin Naqvi. Professor Wasim Asmat Chaudhary.
I would like to request Dr. Tipu sir, chairpersons को sir आपने वो certificate में. Thank you so much, sir. Now I would like to request Dr. Nurul Haq. Sir, can you please come on stage?
Thank you very much for coming to this conference. और अल्लाह के शुक्र से 2 साल के बाद हुई है और काफी जैम पैक चल रहा है और भूख भी लगी होगी. कमिंग शॉर्ट. अच्छा देखिए, सबसे पहले हमने ये किया है कि पीएसए के जो सीनियर लोग जो थे जिन्होंने काम किया है इस कॉन्फ्रेंस के लिए, दे नीड अ गुड क्लैपिंग फॉर देम. और as a token of appreciation, we would like to give some tofa tahaif to them. FDL, please come on the stage. And our first, Dr. Saeeda Haider. Ajay. Madam, लाके दें. Assalamu alaikum. Dr. अच्छा, डॉक्टर सफिया जफर. आ जाए. डॉक्टर नासिर अली फ्रॉम इंडस हॉस्पिटल प्लीज. Brigadier Zahid Raw from Fazaya University. Dr. Dillu Raja from Tabba Kidney. And Dr. Vinod from Indus Hospital. Vinod, please. Thank you, Dr. Saeed. Now I would like to call Usman को. आप लोगों का शुक्रिया बहुत बहुत. FDL, please. हो गए ना? सात थे ना? 7 हो गए. रिवर्स आ गया. सात है. ठीक. अच्छा. Thank you, FDL. Usman साहब, Usman को and company, please. Mr. Kamar साहब, please come on the stage. As a Dr. Shabbir Jumani, please come on the stage to collect his present. Dr. Muhammad Hamid from Aga Khan, please. Dr. Farjad, please come on the stage. And Amin Kabadia from Aga Khan, please come on the stage. अच्छा, आप लोगों को हो गया 5 और है, तो उसका लकी ड्रॉ निकालें. अब सर, प्रोफेसर टीपू, प्लीज कम ऑन द स्टेज फॉर द लकी ड्रॉ. टीपू साहब कहाँ निकल गए? आ जाए सर. वही सर, बस जो जिसका निकलता है उसको हैंड ओवर कर दे.
हाँ, बता दें किसका निकालना है.
अच्छा सर. सर 5 देते. 5. ठीक है. वहाँ पर 2 है ना आपके? कितने हैं आपके? 3 है, 2 है, 3 है. टोटल 5. टोटल 5. मैं खोल के दे दूं सर.
5 lucky persons. उस्मान साहब की तरफ से डॉक्टर सैयदा ऐमन जुबैर,
LNH, लियाकत नेशनल.
सैयद सिराज अहमद, रेसिडेंट एनेस्थीसियोलॉजिस्ट, इंडस हॉस्पिटल. नहीं है, उसके बदले कोई और क्या है? डॉक्टर महमा, MBBS FCPS. SIUT, महिमा नहीं है। हाँ दूसरा ले आओ।
नासिर खान।
डॉक्टर सिदवा जावेद, कंसल्टेंट एनेस्थेटिस्ट, SMBB।
मोहतरमा बेनज़ीर भुट्टो, नासिर खान।
डॉक्टर नासिर खान, PNS शिफा। नासिर खान PNS शिफा है। आ जाओ नासिर आ रहे हैं।
खालिद हसन एक ही
खालिद हसन AKUH। खालिद हसन AKUH।
आप थे सर, रुक जाइएगा सर, रुक जाइएगा। डॉक्टर सहर CHK।
डॉक्टर सहर CHK। डॉक्टर नीता देवी है? हो गया। हाँ सॉरी, गलती हो गई, माफी चाहता हूँ।
5 तोहफे थे, 5 खत्म हो गए, सॉरी फॉर दैट। अच्छा अब हम थैंक यू सर, आप रुक जाइए सर। एगमैन कैंटेक्स वाले आ जाएं प्लीज, जल्दी जल्दी आए, तब सबको भूख लगी हुई है। सर डॉग 2 निकाल दें। सब आ गया, सबको दे दिया, सबको हो गया, सबको दिल्लू ने रिटर्न किया, रखना बस दिल्लू का, ठीक सबके हो गया।
क्या नाम पढ़ो भाई, ये नाम पढ़ो।
अच्छा यार बाद में बात करते हैं उस पर। डॉक्टर सारा जाफरी CHK। डॉक्टर A गफ्फार सऊदाबाद सिंध गवर्नमेंट हॉस्पिटल। हाँ नहीं, एक रह गया ना। डॉक्टर अरसलान, डॉक्टर अरसलान हमदर्द यूनिवर्सिटी हॉस्पिटल। हाँ ठीक है, इसका दे रहे। इंट्रा हेल्थ प्लीज गेट रेडी। इंट्रा हेल्थ, थैंक यू वेरी मच। इंट्रा हेल्थ प्लीज कम ऑन द स्टेज। सर आप रुक जाइएगा सर। सर इधर नहीं, 13 है तो 6 निकाल दें सर आप मुझे फिलहाल। फयाज हसन सीनियर मेडिकल ऑफिसर, ये औरंगी टाउन नहीं, ये तो ये नहीं है। डॉक्टर असफरीन MCPS RMO अब्बासी शहीद नहीं है। Khalid Ahsan, cardiothoracic anesthetist, AKUH. सना आगा अब्बासी शहीद नहीं, अब्बासी शहीद हॉस्पिटल नहीं है। समीउर रहमान, सिंध गवर्नमेंट हॉस्पिटल लियारी। डॉक्टर एहसन पीजी नवाब शाह। डॉक्टर एहसन प्लीज, नवाब शाह। सैयद अब्दुल्ला, HOD एनेस्थीसिया MMI है? नहीं। डॉक्टर वाजिद इकबाल, एनेस्थेटिस्ट, हमदर्द यूनिवर्सिटी। डॉक्टर कोमल, इंडस हॉस्पिटल। वकास खान, इंडस हॉस्पिटल। दूरिया रियाज, आगा खान यूनिवर्सिटी हॉस्पिटल। दूरिया रियाज, दूरिया है कोई? दूरिया रियाज, सॉरी, हाँ अच्छा, दूरिया रजा, हाँ दूरिया रजा, हाँ। और एक है आसिया तकी, ये भी आई है, कॉल है, कॉल। डॉक्टर उमामा, सिविल हॉस्पिटल कराची। डॉक्टर उमामा है। डॉक्टर कानीता, हमदर्द यूनिवर्सिटी हॉस्पिटल। बिहार पे नहीं चलेगा बेटा, बिहार पे नहीं चलेगा। डॉक्टर फिरासत, LRBT। कनीता। अच्छा, सविता S खान। डॉक्टर जुनैद जफर, HOD एनेस्थीसिया, PNS राहत। नहीं, ये तो उनका हो चुका है, रौ जाहिद को मिल चुका है। डॉक्टर सूरज, इंडस हॉस्पिटल। मुकद्दस, नहीं तो ऐसे टेक्नीशियन कहां से आ गए इसमें? एम क्या है? मोहम्मद रफीक, एनेस्थेटिस्ट, LNH है, नहीं है? कितने रह गए तो फिर? आप कौन है बेटा?
डॉक्टर जुनैद जफर।
जुनैद जफर। डॉक्टर सिद्रा जावेद, हो गया, अच्छा चल। डॉक्टर फरहान। डॉक्टर संतोष कुमार, नेशनल मेडिकल सेंटर है? खत्म हो गया, चलें ठीक है, हाँ खत्म हो गया। अच्छा, अब जो इंट्रा हेल्थ फिनिश। अच्छा, इंडस हॉस्पिटल, इंडस फार्मास्यूटिकल आपका तो हो गया ना? डॉक्टर संतोष आ जाए। सना आगा, तो आप कहाँ थी? चल, दे दे, आज है 2 पड़ा हुआ है, किसी और को मिल गया बेटा। चलो तुमको देखते हैं, बैठे रहना, जाना नहीं। अच्छा, इंडस फार्मा प्लीज, इनके 2 हैं सर, 3। अच्छा, इंडस फार्मा ने ये किया है कि लकी ड्रॉ भी कर रहे हैं और ये घर पे पहुंचाएंगे आपको, है? हाँ, उम्मीद है कि घर पे पहुंच जाएगा। बकौल इनके कि संडे का दिन है, दुकानें बंद है, इसलिए इन्होंने ला नहीं सके आज। 3 सर। और दे दो। मिस, ये तो टेक्नीशियन ने दे दिया है। टेक्नीशियन सर, दूसरा दे दे। डॉक्टर नबील, हमदर्द यूनिवर्सिटी हॉस्पिटल। शुमैला अली, सिविल हॉस्पिटल कराची। कितने रह गए? बस हो गए, 3 है ना? तो मैं ना नबील डॉक्टर रशीद मेमन, DUHS। नहीं स्लिप डॉक्टर साहब दे दीजिएगा ना नबील की, मैं लिख लेना यार। डॉक्टर आबिद सोमरो, मारवी अब्बासी, NICVD। बस हो गया सर। तीन हो गए, बस हो गए। अच्छा, असूका, हाँ यार लिख लो नाम।
क्या करना है?
आप अपना नाम लिखवा दीजिए, इनको लिख लेंगे। अच्छा, दिस इज द लास्ट ड्रॉ जो हम वर्कर्स को देंगे। ये असूका पाकिस्तान की तरफ से है सर, आप दे दीजिएगा असूका। सबसे पहले सना आका, जो आप रह गई थी, आ जाए प्लीज ऑन द स्टेज, ताकि आपको कंपनसेशन हो जाए। ठीक। डॉक्टर अफशीन, she also has worked. Dr. Salman, Dr. Rutaba, दूरिया आ गई हैं? दूरिया आई? अच्छा, ठीक है, आज जल्दी से एक दाना और है। अमीन सुलेमान, ये लकी ड्रॉ नहीं है, ये आपने काम किया उसकी खुशी में दिया जा रहा है, यसूका की तरफ से। लकी ड्रॉ तो है ही नहीं ये तो हमने लकी ड्रॉ किया ही नहीं है, ये तो आपने मेहनत की है उसकी। ठीक है सर, बस 2 रख लो भी बाद में। ठीक, अच्छा अच्छा, अच्छा आसिफ, डॉक्टर आसिफ फ्रॉम इंडस हॉस्पिटल। हाँ एक और है सर, रुक जाइए। एलमेड ये गिफ्ट वाउचर दे रहे हैं 5000 रुपीज का, अपने पसंद से जाकर के जो दिल चाहे ले लीजिएगा। सर निकाल दें, है 5000 रुपीज, यस 5000 का निकाल रहे हैं आप। डॉक्टर आसिफ इनको दे दे, एक रह गया ना डॉक्टर आसिफ का, असू का ये भी दिलवा देते हैं, असू का मिल जाएगा। ठीक, बल्कि यहाँ से जाकर के पकड़ लो उधर से उससे। सुनो इधर आओ बेटा, तकल्लुफ नहीं करो, यहाँ से जाओ, वो वहां खड़े हैं वो। अरशद एक रह गया तोहफा, ये रह गया बच्चे हमारा। काशिफ LUMS, हाँ हाँ ठीक है, लियाकत यूनिवर्सिटी। काशिफ मेमन साहब, ठीक है ना, आप जाते हुए भाभी के ले जाइएगा 5000 का तोहफा। देखो दूसरा देखो, डॉक्टर शम्स इकबाल फ्रॉम NIRM, नहीं क्या फ्रॉम इस्लामाबाद हैं वो। शम्स इकबाल, नहीं किसी और का निकाल देते हैं। डॉक्टर समर नईम, लेडी रीडिंग हॉस्पिटल पेशावर, निकालो ना, बहुत सारे हैं। डॉक्टर फराज शफीक AKUH है, ये निकल गया ये भी। नहीं नहीं आपको मिल गया बस, ये काफी नहीं है, है? अनम मोगल CHK, अनम मोगल। और कितने रह गए? डॉक्टर आफ्ताब PNA शिफा, डॉक्टर आफ्ताब है, आ जाए आप। हाँ दूसरी दे दो। कितने रह गए और?
एक रह गया बस वो।
अच्छा, डॉक्टर फैसल खान AKUH, AKUH ने काम ही आज यही किया, भरा है लकी ड्रॉ
सर ये
है। हाँ जो तुमको दे दें। डॉक्टर तारिक महमूद PNA शिफा, लगता है PNA शिफा वालों ने भी एक ही काम किया है आज। और दो भाई, एक पर्ची रहेगी लास्ट।
वही नहीं आप।
हाँ। सज्जाद काजमी, ठीक है लाहौर, सज्जाद काजमी लाहौर। जो मैं अपने नाम ही निकलवा लेता हूँ ये होगा। तारिक अजीज पिंडी, रावलपिंडी। नजीबुर रहमान हब चौकी। तारिक साहब आ रहे हैं, आ जाए तारिक साहब। चले हो गया, चलें जी, 5000 तो जीता आपने। आपका और फ्री है ना अब तो, आपका खत्म हो गया, 3-3। Thank you very much. I am handing over the stage to Professor Tipu Sultan for business session.
थोड़ी सी खामोशी हो जाए तो बेहतर है, क्योंकि मोस्ट इम्पॉर्टेंट सेशन है ये, और क्विकली हो जाएगा क्योंकि लंच तैयार है मेरे ख्याल में। दिस इज द रिजल्ट ऑफ PSA कराची चैप्टर of Pakistan Society of Anesthesia. Traditionally, we conduct this election by consensus. So these are the new office bearers of PSA Karachi. और जब उनका नाम लें तो यहाँ तशरीफ ले आइएगा. President Dr. Amin Khwaja. President-elect Dr. Shabbir Jumani. Vice President Dr. Ali Sarfraz. General Secretary Dr. Asma Abdus Salam. Joint Secretary Dr. Ashok Kumar. किधर है? वो भी नहीं. Treasurer Dr. Dillu Raja. And we have got the big chief of Karachi. Guess who? Big chief of PSA Karachi. Dr. Saida Haider, patron PSA Karachi. Now I will read the names of executive committee members. After that, I will request the president to give a little speech. बाकी लोगों की जान बख्शी. हाँ, outgoing president, yes, sorry. Hamid. Outgoing GS किधर है? तुम भी आ जाओगे. Executive committee members, Dr. Akhtar Wahid Khan, Dr. Akhtar Aziz Khan, Dr. Professor Fauzia Anis, Professor Sadka Aftab, Professor Nurul Haq, Professor Zahid Akhtar Rao, Professor Safia Zafar Siddiqui, Professor Gauhar Afshan, Professor Nikat Abbas, Professor Samina Ismail, Professor Alia Ahmed. Dr. M. Amin Anwar, Dr. Zahid Salod, Dr. Amin Suleiman, Dr. Zia Akhtar, Dr. Nabila Nasir, Dr. Shoaib Malik, Dr. Muhammad Abbas, Dr. Rajesh Gandhi, Dr. Aftab Ahmed Khatri, Dr. S. Talal Ahmed, Dr. Vinod Kumar, Dr. Nasir Ali Rahimi Najad, Dr. Nasir Khoso, Dr. Anam Mughal, Dr. Hamid Mahmood, and 3 members of the executive as an ex officio, Dr. Muhammad Hamid, Dr. Syed Farjad Sultan, and Dr. Hamid Ali. So now we have got our cabinet here and a good number of executive committee members. This was my pleasure, like every time, to announce these results. Traditionally, there is no fighting for any post here. Whosoever wants to become president, general secretary, joint secretary, raise your hand. अगली दफा आपका नंबर आ जाएगा. कोई पंगे की बात नहीं है. और मकसद सिर्फ दो ही है कि should be hardworking and should be honest. And we have got a whole galaxy of our very hardworking galaxy of anesthesiologists and we are so lucky for that. Now I would like to request 2-3 persons, the outgoing General Secretary, just few words.
Assalamu alaikum. Thank you very much. I think wrap up karke khana announce karna hai. So we're just going to take a photograph, and thank you very much for this great conference. A huge thank you to the executive committee and all the seniors and junior colleagues who have helped us throughout all of this, and a big hand of applause for all of you to attend. There will be a workers' dinner or a workers' iftar. We will announce it at a later date once we come to a consensus. And with this, I'm going to close the session. Thank you very much. Lunch has been served. Thank you.
Outgoing President Dr. Hamid, please. Few minutes only.
Assalamu alaikum. I'm really grateful to all the executive committee members for their support and tolerating us for almost 3 years. 3 years is actually a very good time. It's supposed to be a 1 year tenure. Yesterday we already discussed what we did in the last 3 years, so I'm not going to go into the detail. Just few suggestions for the new cabinet. That first of all, the newsletter, we should continue with the newsletter quarterly rather than yearly. And if we can convert it into a journal, that would be a great help for the PSA. And then we were working on the minimal standard of anesthesia at different institutes. So if we can continue that as well. Another thing about the resident, there was a lot of abstract and posters, but there is a ethical review committee at PSA level as well. So if you have any surveys or audits, you can always contact the PSA to have any surveys among the anesthesiologists which are attending or other places as well. So I thank you again for all the support and congratulating all the new cabinet members and wish them luck. Thank you.
Thank you, Hamid. And now I need a big clap for our new president, Dr. Amin Khwaja. Dr. Amin Khwaja, please.
Thank you very much, sir, and thank you. PSA, the main purpose of PSA is to promote an academic activities and promote the new trends, whatever like an ultrasound and all the things. So do an hands-on workshops and all things. So the COVID is over. I will try my level best and I will support all the hospitals if they are going to arrange the symposiums and the CMEs. And the lacking in the anesthesia is the research work. The good thing is this time that more posters and the paper presentations were presented in this conference. But I will say we have to do a lot of research work. That's how we are going to promote the anesthesia specialty. And second thing is these papers should be published. We should try, these papers should publish in the international journals, because in the local journals, they are also good. But if we promote these activities in the international level, that will be the good one. And I thank you, all of you, and hope all of you will support me. Thank you very much.
Thank you so much, Dr. Amin. Lunch is to be served for everybody. It's by the poolside, and for the senior faculty and consultants, it's at Dampocht. Thank you so much. This is the end of the PSA conference, and we will also, Dr. Sophia. Gigi, lunch is in Marquee for everybody. Okay, and for the senior faculty, it's in Dampocht. Okay. Acha, one thing more, for the participants of the poster competition, The certificates of participation is to be presented. Please line up and you'll get the certificate.